invasive device is vital signs, date of collection of the catheter line tip, blood specimen, and antibiotic therapy. Statistical analysis was performed using SPSS version 17. The results were generated in tables and figures, and the p-value of less than 0.05 was used. Risk factors were determined with multi-nomial logistic regression analysis. The results: 68 patients were recruited for this study, but 3 were excluded because the catheter was removed without prior catheter colonization from this study, and central venous catheter-associated bloodstream infection was 9%. The age range was from 19 to 70 years. One patient, 2.3% of the total number, had catheter-associated bloodstream infection when the catheter was removed at less than 5 days. We have 5, that's 2.7% of our patients have catheter bloodstream infection when the catheter was removed after 5 days. There was no significant association between presence of other invasive device, indication for the catheter placement, and bloodstream infection. Catheter tip culture yielded Staphylococcus aureus at 16.9%, E. coli at 6.2%, Streptococcus at 10.5%, and the Enterobacter species at 1.5%. One culture was positive in 6 patients, and the same organisms were also isolated, and the other was Staphylococcus aureus was 4.6%, E. coli 3.1%, and Salmonella typhi 1.15%. Antibiotic sensitive pattern showed gentamicin to be the most sensitive at 70.3%, imipenem 51.4%, fluoxacillin 40%. Pseudomonas enterobacteria species were shown to be 100% highly sensitive to imipenem, where Pseudomonas is 100% moderately sensitive to fluoxacillin. Streptococcus has the highest sensitivity with cotrimazole alone. 23 patients, 62.2% were resistant to augmentin. These results are shown in table 1 to 7. However, because of the time limit, I might not be able to go through these tables, but they are shown in table 1 to 7. Those are the tables. Okay. For the discussion, the national devote central venous catheter ranges from 2 to 4.5% per 1,000 catheter days. Incidence in this study is much higher than these rates. The duration of the catheterization was the only risk factor that was found in this study. This was similar to findings by Cheng et al. However, Vasikili et al. Have much lower rate than our findings. Gram-positive Staphylococcus aureus was shown to be the organism with the highest prevalence rates. It's in agreement with other studies, especially those by Cheng et al. But however, Vasikili et al. Showed that gram-negative organisms were the most predominant organisms. These findings is suggestive that perhaps the organisms result from either during insertion or from the patient normal skin flora. So the need to use more asepsis during the insertion of these catheters. In conclusion, the duration of this catheterization was found to be a major risk factor for central venous catheter bloodstream infection. The most predominant organism was Staphylococcus aureus, and the most sensitive antibiotic agent was aminoglycoside gentamicin. Those are references. Thank you very much. Hello.
Okay, thank you very much, Dr. HG, for the brilliant presentation. You just finished talking to us on the role. Okay, you just finished talking to us on the incidence of central venous catheter line infection in patients admitted in the intensive care unit of the University of Nigeria Teaching Hospital, Enugu. Thank you, Dr. Amucheze. Please, if we have questions for these presenters, you can type them in the chat or you can raise your hand at the end of the session. Now we are moving on to the next presenter, which is Dr. Yakubu Amisu. He sent a message that is not available. I don't know if he's here with us, if the slides are ready. That's the role of non-invasive ventilation, that's CPAP, in the management of severe pulmonary edema in a patient with poor response to diuretics. Dr. Yakubu Amisu. Thank you very much.
Hi everyone, I am Dr. Yakubu Hamisu from Department of Anesthesia, Ahmad Bello University Teaching Hospital Zaria. I'm presenting a case report on the use of CPAP in the management of severe pulmonary edema. A 35-year-old multipara who had poor response to diuretics, who was managed as a case of acute pulmonary edema in the immediate postpartum period and had poor response to diuretics. However, she responded well to non-invasive ventilation, CPAP. The case report is just to highlight the aim is to highlight the use of NIV, the management of acute pulmonary edema in patients that show poor response to diuretics. She was a 35-year-old para 6 who presented about 6 hours after home delivery in severe respiratory distress with peripheral oxygen saturation of 56% in room air. She was passing pink frothy sputum and had a tachycardia of 141 beat per minute, hypertension of 180-120 millimeter of mercury, and had sounds S1, S2, S3. Tachypneic respiratory rate of 40 cycles per minute, and had widespread crepitations, coarse crepitation in both lung fields. Her point of care chest ultrasound was done, which revealed multiple B lines, which were indicative of pulmonary edema. Her left ventricular ejection fraction was 49%, slightly was poor. She had a proteinuria of 3 pluses. ABG was not immediately available in the facility. She was diagnosed as a case of acute left ventricular heart failure with acute pulmonary edema secondary to severe preeclampsia. She was admitted into the ICU and was placed on oxygen 15 liters per minute. She was given IV furosemide 40 milligrams stat, which was repeated after 30 minutes. She was maintained on furosemide 40 milligram 8 hourly. She also received sublingual glyceryl trinitrate GTN 0.5 milligram, which was repeated after 5 minutes, and IV hydralazine, both for BP control. 2 hours after commencement of management and after administration of 120 milligram of Lasix, she was not diuresing adequately. She was making just less than 0.5 mils per kg per hour of urine. Her SpO2 only improved to 74%. She was still hypoxic. BP worsened and became 210 over 135 milliliter of mercury despite hydralazine and glyceryl trinitrate administration. The decision was made to commence non-invasive ventilation. She was placed on CPAP mode with a PEEP initially of 10 centimeter of water, which was increased to 13 centimeter of water. She was also commenced on isosobide dinitrate infusion for BP control. And after 2 hours of CPAP and isosobide dinitrate, she showed some improvement. SpO2 rose to between 82 to 90%, and subsequently after 8 hours of CPAP, it improved to 94%. Her blood pressure dropped to less than 160 over 110 millimeter of mercury. she improved significantly on the second day of admission, and she was weaned off CPAP, and now to nasal prongs, and later on the same day to was placed in room air when she was saturating 94 to 95 to 98% in room air. Her urine output, however, was still poor, still less than 0.5 ml per kg per hour, despite furosemide 40 milligram each hourly. At that point, the furosemide was increased to 80 milligram, and when her urine, the results of her serum urea, electrolyte, and creatinine came out, there was some derangement. Urea of 51.8 milligram per dl, which is slightly above the upper limit of normal. The creatinine was 2.5 milligram per dl, which is like 2.5 times the upper limit of normal. On the third day of admission, her urine output improved to 0.5 ml per kg per hour. And the BP was fairly controlled, and she's now on oral antihypertensives. She was now then on oral antihypertensives, and left ventricular ejection fraction improved to 55%. The chest became clear, and at that point she was referred to see the nephrologist and cardiologist for further management. Discussion. Acute pulmonary edema is a major cause of maternal morbidity and mortality. It has an incidence of 0.08% in the peripartum period, with hypertensive disorders being one of the principal etiologic factors. Patients who have renal impairment, such as the index patient, show poor response to diuretic therapy, which would have cleared the lungs of fluids, excessive fluids. If the patient if any patient remains in respiratory distress, acidotic or hypoxic despite supplemental oxygen, non-invasive or even invasive ventilation might be indicated, such as in the index patient. The application of high PEEP to the CPAP helps to clear fluid from the lungs and improve oxygenation. The index patient had poor urine output despite diuretic administration and remained hypoxic despite high flow oxygen. And the good response to CPAP she showed supports the decision to use NIV, non-invasive ventilation, in the management of severe pulmonary edema. In conclusion, acute pulmonary edema can result in respiratory failure. The oliguric patient may show poor response to diuretics, and they tend to benefit from positive pressure ventilation, ventilatory support like CPAP and BiPAP. Thank you for listening. Any questions, comments, or contribution would be appreciated. These are my references.
Yeah, thank you, Dr. Yakubu, for that brilliant presentation. Dr. Yakubu just talked to us about the role of non-invasive ventilation, CPAP, in the management of severe pulmonary edema in a patient with poor response to diuretics. So thank you so much, Dr. Yakubu, once again. Now we have done all these presentations. If you have questions, comments, please type them in the chat box. And please, our host, Mr. Ediomi, try and make the presenters co-hosts so they can take their questions. So before we take the questions, I want to call on the rapporteur, Dr. Amucheze Ada, to give us a brief summary of about a minute each of these presentations, so that those who just joined us can catch up and get a brief of what we have done so far. You have the floor now, Dr. Amucheze. Thank you very much. Mr. Ediomi, please unmute her. Thank you.
Thank you, Dr. Koje.
Yeah, thank you, Dr. Amucheze. You're welcome.
Thank you. Yes. The first presentation was on the comparison of GKI against intermittent boluses of insulin for the control of blood sugar during the perioperative period for patients undergoing general anesthesia. And they concluded by saying, after the study on 68 patients, that both methods using the glucose, potassium, insulin, and intermittent boluses of insulin, they had comparable effects on the perioperative maintenance of the patient, and that the intermediate bolus of insulin also, unfortunately, that group had more hyperglycemic incidents and more hyperkalemic incidents. And then the insulin infusion group required used more insulin. Therefore, they concluded by saying that the intermediate bolus of insulin can be adopted as a technique for maintaining blood sugar during patients undergoing anesthesia under general anesthesia. The second presentation was on the a case report of malignant hyperthermia, a rare but fatal perioperative complication of general anesthesia. This happened in a 5-year-old that was booked for bedrock ductal atherosclerosis ligation and developed hyperthermia with severe sweating during intraoperatively, about 38 minutes to the end of the procedure. They started therapy, cold IV fluids, gave paracetamol, but unfortunately they didn't have dantrolene in the hospital and they couldn't perform the caffeine and halothane contraction test. So they advised that hospitals should make dantrolene available for their patients. The third presentation was on the evaluation of incidence of central venous catheter-associated infections in the ICU of the hospital in Southeast Nigeria. And they found out that the commonest organism was Staphylococcus aureus. The risk factor associated with the development of infection was duration of catheter, that's the central venous catheter, and that the presence of endotracheal tube or urinary catheter had no effect on development of infection, and that the antibiotic that was most to be used in the treatment of infection was gentamicin. The next case was the topic was the use of non-invasive ventilation, CPAP, in the management of severe pulmonary edema in a patient with poor response to diuretics. This was a woman had delivered, but now presented in the hospital with severe hypoxia. They had given oxygen intranasally, but no response. So they were now switched over to CPAP, and there was much improved response, up to the point that the patient, within 2 hours of commencement of CPAP, the oxygen saturation moved to 80%, while within 24 hours, it had risen to 94%, and the patient was weaned by the second day of admission. So they concluded by encouraging us to think about using non-invasive ventilation mechanisms for patients who have severe pulmonary edema while treating the underlying cause. Thank you.
Thank you, Dr. Amucheze. That was a very brilliant and concise summary, and I hope we all got that for those of us that joined us late. Okay, now we are going over to the chat box. We can see a lot of questions and comments on the chat box. Now, the first the first question on the chat box is from Dr. Tasio Sadu. And this is directed to the first presenter, that's Dr. Oshipidon. I don't know whether they've made her maybe a co-host, so she can, okay. Madam President, your hand is up. I think you can unmute her so she can make her comment.
Thank you very
Thank
much.
you, Madam
Good
President.
morning. Thank
Good
you.
morning.
I want to congratulate all the presenters on this session, and I want to thank them for sharing their work and their experiences with us. I have a few comments and a few questions. My first question goes to Dr. Idris. Thank you very much for your brilliant presentation. I want to ask, the diagnosis of malignant hyperthermia, was it confirmed? If not, then I suggest you would like to call it suspected malignant hyperthermia or query malignant hyperthermia. And the lessons learned are good, and we need to be on top of our game at every time. However, I'm not sure that we really know the mortality rate in Nigeria or in Africa. Is it possible to find a way to get an idea, or to do a study to get an idea, or to do a review to get an idea of what could be the mortality rate in our environment? And that is for Dr. Idris. My second question is for Dr. Amuchiazi and colleagues. I want to ask, how can we prevent this infection of central venous catheters, apart from the general things that you have said in your paper? Is there anything that you can advise us as practitioners, especially those of us that work in the ICUs, in order to prevent this infection? Then my last question is to Dr. Hamisu Yakubu. Thank you for your presentation on use of CPAP for management of pulmonary edema. My worry is that right from the beginning, the patient was oliguric and had signs of acute renal failure. So my worry is concentrating on giving CPAP and trying to dry up the lungs, whereas the kidney is failing, and that aspect is not managed promptly. How does that improve the outcome, the eventual outcome of the patient? That's one. The second thing is your presentation stopped at her being referred to the nephrologist. What was the eventual outcome after that point? Were you able to follow her up to know what really happened? And also, what was the outcome of the baby? Thank you.
Thank you very much, Madam President. And I hope the presenters are noting the questions and the person asking the questions. So I will take the other questions on the chat box so you can respond at the end of it all. Or you can respond as on the chat if it's something you can easily take on the chat. Now we have this question from Dr. Tasiu Sadu. He's asking, thank you for your presentation. Why do you choose 5 international units of soluble insulin for intermittent dose insulin in your study? That's for the group that had the intermittent dose insulin. Why did you choose the 5 international units of insulin? I think that question has been answered. He said, based on previous studies, that was the safe dose used, and also to make it comparable with the GKI group where the 5 international units of insulin was used. Dr. Tasiu, I hope that answers your question. I guess the presenter can also throw more lights when it's time for them to respond. Then this question is from Dr. Aguwe. He's asking, why was this patient with malignant hyperthermia extubated immediately after surgery? I'm sure that's for the presenter with the rare incidence of malignant hyperthermia. Please note the question. Then how frequently should the intermittent boluses be given, considering the recent study? That's a continuation of the former study, of the former question by Dr. Tassiu. Is asking how frequently should the intermittent boluses be given, considering the recent study you cited. Then for the second presenter, she said, I also want to know why you extubated this patient despite the fact that the symptoms of MH were still present. I'm sure everybody is interested in why this patient was extubated. Then another question from Teresa Orensawan. She's asking, considering the hypermetabolic nature of malignant hyperthermia, why wasn't blood samples taken for electrolytes, urea, and creatinine levels? Why was ABG not done? Yeah, this is from Associate Prof. Tonia Onyeka. She said, what were the issues discussed with the parents? Or what were the issues discussed with the parents of the child after this event? Okay, were the issues discussed with the parents after this event occurred? Were the parents briefed? She's trying to find out. So I think we can respond to these questions for now before we take the other set of questions. Please, Mr. Ediomi, are they unmuted? Dr. Oshun Pidon, are you here?
Yes, ma'am. Good morning, ma'am.
Good morning. Please respond to the questions. Thank you very much.
Yes, ma'am. Good morning, my teachers. Good morning, colleagues and residents present. Thank you very much for the opportunity given. Like I already explained before, that it was the intermittent bolus given was 5 international units, because to make it comparable with the GKI group where we had 5 international units given initially. Then our aim was to maintain our blood glucose level between 6 to 10 millimoles per liter. So, and also when we consulted with the endocrinologist, that was the dose that was saved that will not cause a significant hypoglycemic effect. That was why we used 5 international units of insulin. Then also the intermittent bolus was given only when the blood glucose was found to be less than 10 millimoles per liter. After we had checked the blood glucose level was checked every hour till 2 hours postoperatively. The blood glucose level was checked every hour. So it was when it was checked and found to be 10 millimoles, greater than 10 millimoles per liter, that the intermittent bolus was given. However, when it was not greater than that and remained within 6 to 10 millimoles per liter, there was nothing done. Rather, it was just the infusion that was continued at 125 mils per hour for 5% dextrose. Thank you very much.
Thank you, Dr. Shupendo. We have the other presenter to respond to the questions. That's Dr. Idris and Dr. Yakubu. Is Dr. Idris here?
Dr. Yakubu is here.
Okay, thank you, Dr. Yakubu. Please respond to the question.
Yeah,
thank
good
you.
morning, good morning all.
Good
thank
morning.
you for the observations and comments and the questions. The question was why the renal impairment was not tackled earlier and the follow-up. Actually, she presented in respiratory failure. So all our attention was on management, on bringing her out of the respiratory failure. And normally what we expected was she would have responded to Lasix by diuresing. And that was when our mind got to the renal impairment aspect. So when the results came out, it spotted the thinking that there was some renal impairment, and by then she was already out of respiratory failure, so she was referred to see the nephrologist. And yes, she was followed up, and we found that she did well. The renal function came back to normal, and she was urinating. She was making adequate volume of urine, so she did well eventually, and continued her follow-up with them. Thank you, ma'am.
Thank you very much, Dr. Yakubu. Is Dr. Idris on now? Because he seems to have a lot of questions and we want answers. We're interested. Okay. Mr. Idiomi, try and unmute him if he's there. Is Dr. Idris on this call? Mr. Idiomi, is he among the participants?
He said he can't unmute himself, something like that.
Okay, I guess if we just type the answers. Okay, so we'll go over to the chat box, and we still have some more questions. This is from Dr. Awuda to everyone. She's asking, I'm sure this is directed to Dr. Idris again. A respiratory rate of 62 cycles per minute is in this patient with malignant hyperthermia. Is mechanical ventilation not indicated while on admission in ICU? That's a question on that again for Dr. Idris. Then this is from Dr. Awudesu. She wants to find out why was this patient taken to PACU first and not straight to ICU? Was there any precipitating factor to the patient developing MH intraoperatively? That's another question. Then this is from Dr. Teresa Orensawo to Dr. Idris again. Considering the child had PDA repair, shouldn't the volume of cold fluids needed be a concern? Would it have been possible to pass an NG tube and lavage continuously with the ice cold fluids? Also, were the parents counseled and advised accordingly? Thank you very much. Then, okay, let's see. Then this is from Dr. Aderonke Obishashon. She wants to know, I was wondering why the patient was extubated immediately post-op and why the option of elective post-op ventilation was not considered. Okay, so those questions were already asked before. Why was this patient, this is from Dr. Oladapo Olubukola again. Why was this patient extubated immediately again? This same question keeps repeating. Okay. So please, Dr. Idris is asking to be unmuted so he can respond to all these questions. Please, Mr. Idiomi, please, can you unmute Dr. Idris?
He is now a co-host.
Okay. Dr. Idris, please, you're on. You can unmute yourself and talk.
Oh, hello, ma. Good morning.
Good morning. Thank you for joining. Yeah, please respond.
Thank you, ma. Sorry, I could not unmute myself all this time. Thank you, Prof, for your observation and questions, ma. Actually, just like I said, the confirmation test was not done. The confirmation, which is the halotene contractual test, was not done because we were not suspecting the condition, and also the post-op intraoperative after the diagnosis we could not do that because the tests available for that was not material for that test was not available in our hospital. Dantrolene was not used, just like I said earlier, because we don't have it in our hospital, which is very important to bring down the temperature and bring down the condition. Yes, the reason why we extubated the patient in the theater, despite the diagnosis was believed that the patient had is malignant hyperthermia, was that she was actually, after the surgery, after the reversal, she was breathing spontaneously, adequately, and was actually fighting the tube. So we decided to extubate. And probably we are not sure whether it is done because there are other differential diagnoses, the thyrotoxicosis and other things that has all the features, the fevers, they say they all have those features. So we thought it is not one, but at the end of the day, by the time we extubate and observe for some time, go to recovery room and the ICU, the patient still maintain the condition. Yes, the 62 tachypnea of 62 in our hospital was the respiratory rate is above 35, of course, we put patient on the ventilator, paralyze and ventilate electively. But in this case, we actually made that make that effort. She, just like I said, she convulsed twice. We gave that, and after that, we attempted we intubated. Continue after the second dose of the diazepam, we intubated and treated that, but the conditions never come down to normal until the patient died 6.5 hours later. Somebody said, is there any precipitation? Of course, in the precipitation, the most important factors that cause the malignant hyperthermia is suxametonium and inhalational agents. And from the studies done, all the inhalational agents, allotane is said to be the one that precipitate the condition earlier than any other of the inhalation agent. All those, the condition, we hear the factor in suxametonium and allotane are precipitating factors in this patient. So we did all we can. The lavaging that somebody is asking, yes, we did is something even better than that. Instead of we gave a cold IV fluid, what we did, we cold fluid from cold water from fridge was used to cool our IV fluid before we give it to the patient. Lavaging could also help actually, but we didn't do that, but we did give a cold IV fluid. We did tape with cold water and then ventilate and ambient temperature also. But the dantrolene, as we said, was not available in the hospital. It's a rare condition and it's not even expected. So with this presentation, we expect the management to have provide the dantrolene at the end of the day. Now, my prof also asked that whether we discuss the child mother. Yes, we did. Usually, it's whenever we lose a patient in ICU or theater, we call the patient and debrief the patient. So we call the patient's mother. We discuss all the conditions, what happened in the theater, why the surgery went off smoothly until towards the end of the surgery, the patient developed malignant hyperthermia, and we make all effort to bring the condition down. But in fact, when we were even moving the patient to ICU, they were with us. One of the relations, the father went with us to ICU. She saw what was happening and all the effort we put into to bring down the temperature. In fact, though we suspected we were not able to get the result for lab, but we still went ahead and gave empirical bicarbonate in case of acidosis. We took blood actually for urea and electrolyte, but the result was not out before the patient died. And when the result came out, actually, they were all deranged. Thank you, Ma. I don't know whether there are any other questions.
No, Dr. Idris, thank you very much for that detailed explanation. And we hope all those that asked questions, at least we answered the questions and are satisfied with the answers. Okay, so at this point, we want to thank everyone for listening, for joining us in this session. We are now going on to the Komen presentation, one of our sponsors, Komen. We don't know if they are ready. We want to take your presentation for your adverts, your product videos. Thank you very much. I can see Mr. Frank Liu. Thank you for joining us. I think you have the floor right now. Thank you very much. So, Mr. Idiomi, you can go ahead to take it, put up the slides. Let us listen to the presentation.
Okay, thank you for the reports today. Please allow me to, since we just now talk about the SAVE-AD process, now please allow me to have some introduction of our SAVE-AD products. Okay, so please allow me to, after the video, please allow me to have a brief introduction of our catheter positioning device, the U8. And now please, which could significantly improve the efficiency of catheter positioning and reduce infections in the cathetering process. And let's know about it from three aspects. Firstly, the product positioning, what does it used for? Our catheter positioning device, U8, is the most comprehensive CVAD solution in the market with ultrasound and ECG positioning technology. So it refers to, so what is CVAD solution? It refers to the application of central venous access devices for patients who need administration of fluids, blood products, and other drugs. It could be applied in various hospital departments, include anesthesia, emergency, ICU, oncology, etc. Generally speaking, CVAD includes PICC, CVC, and port, which are frequently used clinical methods in cathetering. Here is a comparison of the three CVAD methods in terms of their cost, dwelling time, advantages, and disadvantages. Compared with the central venous catheter, the peripherally inserted central catheter, which is the PICC, has a longer time of indwelling time and less risk of infection, which is more frequently used method in clinical situations. So take PICC as an example. There are two key steps in conduction. Firstly, it is to place the cannula into the vein. Traditionally, the conductor might puncture blindly, which might highly rely on their experience and might lead to repetition of cannulation. However, ultrasound is being nowadays is being widely used to improve the accuracy of cannulation and reduce the repetition. And secondly, is to ensure the cannula teeth being placed at the right position. Normally, X-ray is used to provide visual confirmation, but there are certain shortcomings of this method, such as repetition and inaccuracy led by the error diagnosis from the radiologists. So alternatively, nowadays the ECG guidance is being used to provide real-time information of the positioning of the catheter teeth. And nowadays, more and more academic reports have shown that ultrasound-guided puncture could significantly increase the success rate of cannulation. And it takes less time, and of course, it could reduce the repetition of punctures. Therefore, the patient's satisfaction could increase also. And also, similarly, the ECG-guided method has been an innovative method for PICC teeth positioning. The principle of ECG-guided positioning is based on the P-wave fluctuations. This method has been recognized effectively and accurate. Many developed countries have applied ECG-guided method in performing PICC or CVAD placement. And there are certain advantages of ECG-guided PICC positioning method. Firstly, it is accurate, simple, and without frequent exposure to the X-ray. And also, secondly, it is a non-invasive method and could provide real-time monitoring. Therefore, the catheter positioning could be adjusted once there is any mistake in the catheter positioning process. And in addition, it also has been academically and clinically proven that the ECG-guided technique could be used for neonates in catheterization. After knowing the most up-to-date and effective techniques that are being used on CVAD solution, please allow me to introduce our U8, a catheter positioning guiding system that combines ultrasound and ECG positioning technology. and it could meet all the clinical demands of CVAD solution. Now let's have a brief knowledge about the features of our U8. Firstly, the mobile and portable design. As you can see from the picture, it has a large and clear image provided by the screen. It is a highly resolution capacitive screen, and it is also quite easy to use. We have some user-friendly UI designs. It is also lightweighted and portable. Of course, it is solid and durable, made of good, high-quality metals. And we also have a mobile solution. With this trolley, you can use the catheter positioning device within the hospital. Also, it could support an external printer to give convenient printout of the reports. Now let's know about the details about the ECG guided positioning technology used on our U8. Actually, the tracer ECG positioning technology on U8 is developed by Coleman in collaboration with experts from top-grade hospitals in China. And the theory of the ECG positioning system is that you need to put the catheter end at the junction of the lower 1/3 of the superior vena cava and the right atrium. So how we can ensure the accuracy of ECG positioning? Firstly, we have the Coleman's patent-owned ECG filtering algorithm, which combines ECG digital signal and analog signal to ensure the real-time and accuracy waveform. Also, another feature of U8 is the application of two-lead ECG comparison. In the in vitro two-lead, it is normally stable and could be used as a reference. So when the in vivo two-lead changes, while the in vitro two-lead does not, it could provide a good reference for doctors and nurses to know about the position of catheter tip. And in addition to the two-lead ECG comparison, our U8 also provides a smart tip positioning system, which could present a real-time simulation video of the catheter tip position. Coleman also has a special patent for this technology. Correspondingly, we developed a special 4-electrode ECG accessories to realize the accurate ECG positioning process. And then let's know something about our ultrasound technology. It is specially designed for PICC, CVC, and port. And our ultrasound integrates multi-high-end imaging technologies, unique guidance software, and also specialized ultrasound transducer. All these technologies could be greatly improve the efficiency of catheter placement and prevent possible complications. Firstly, a series of ultrasound imaging technologies has been adopted to provide clear image in catheterization. Firstly, we have a large capacitive screen and also a series of ultrasound imaging technologies being used on this machine. So the ultrasound image could be very clear for the doctor's reference in catheter position, in cannulation. And another unique guidance software is also developed to facilitate the puncture process. First one is the intelligent indicator of cannula size. Then there are center line and bright line display to contribute to the positioning of veins and cannula. And finally, there are puncture enhancement and catheterization guidance to ensure accurate puncture and smooth catheterization. Our U8 is also equipped with high-end and reliable ultrasound transducer, which is waterproof and could control the working mode could control and switch the working mode between ultrasound and ECG positioning. In this way, the doctors don't have to touch the screen so it could prevent some possible infections during the operations. So in summary, U8 is the most comprehensive CVAD solution in market at this moment, featured by its ultrasound and ECG positioning technologies. Now let's say the competitiveness of our product in the market. Firstly, as a highly innovative product, U8 adopts the most up-to-date ultrasound technology to improve the success rate of one-time puncture compared with the traditional blind tape-measured guided inserting methods. And also in terms of the catheter tip positioning, ECG guided technology could provide real-time information of catheter tip position and effectively reduce the application of X-ray in confirmation. And right now in the market, there is only one competitor, which is the BD's StatRite 8. And here is a comparison. We have a lot of advantages, several advantages in terms of the ultrasound technology and also in the ECG positioning technology. And we have a series of ultrasound images available, 2D plus CMF, and B ultrasound plus D ultrasound, and also a compilation of them to ensure high quality image in catheterization. So in summary, we have a clear image, we have more options for transducer, and we could provide more convenient positioning system, including the ECG positioning system, tip confirmation system, and also we have a special accessories designed for the smooth operations in the CVAD solution. So that's it for our catheter positioning device. Thank you. Thank you, thanks. Do you have any questions? Excuse me, no, it is not limited to central venous cannulation. You can use it in all other, you can use the ultrasound function in all other applicable situations. Actually, it's not limited to central venous cannulation. Okay. Okay, so if you are interested in our U8 device, you can contact our local representative, Mr. Hosala, and he has already sent his contact info in the chatting area. Thank you. Hosala, could you please share your contact info in the chatting area? Thank you.
Thank you, Mr. Frank Liu. Thank you for the presentation.
Thank you.
Yeah,
Thank you.
That was brilliant. Please, if you have questions or comment, please type it in the chat box. Or if you want to ask a direct question, you could raise up your hand so we could entertain questions. Please, the contact of the of COME is on this chat box. You can place your Nigerian contacts again so the participants can reach you. Please,
okay.
you need to repaste it on the chat box.
Okay.
So it can be widely circulated so they can reach you after the presentation. But if you have a direct question for him, you can go ahead to ask by raising up your hand, you'll be recognized. Or you can type it in the chat box. Yes, Dr. Bossade Petros is asking for the contact information, your contact.
Okay, I'm sending our local.
Then this question is from Dr. Ayodeji Dambo. He's asking, can the U8 be used for peripheral nerve blocks?
Yes, it could be. Actually, it could also be used in the neurology department. So I think it could be used for the peripheral nerve blocks. Yes.
Okay, thank you very much, Mr. Frank.
Okay.
So the email of COME is right there on the chat box, and the phone number, the Nigerian phone number. So you can always reach out to get this
Mr.
product
Host,
for your use. Yes.
You can contact
Thank
our
you.
local representative. Okay, thank you. Thank you.
Please, Mr. Ediomi, can you unmute Dr. Morayo Salawu? So in the absence of further comments on the comment from the comment group, thank you very much, Mr. Frank Liu. Thank you for the presentation. We are now going on to the second session of the scientific papers. So please, if we have Dr. Morayo Salawu, Mr. Ediomi, please, can you unmute my co-moderator? Okay,
Hello.
I want to introduce Dr. Morayo Salawu to my co-moderator to take over the moderation of the next session of scientific papers. We have brilliant papers lined up for us in this second session, and we'll be glad to listen to each and every one of them. We hope we have the presenters and the speakers, they are all present to take their papers. We have Dr. Oladimeji Moturayo, Dr. Tokwala, Dr. Ranu CIO, Dr. Adesina AO, Dr. Nwoye, Dr. Akinwale, and Dr. Biklis. Hope you are all present in this call. Thank you very much. I now hand over to Dr. Morayo to take over. Thank you very much, Dr. Morayo. You have the stage.
Thank you very much. I hope we have all been enjoying the conference so far. My name is Dr. Salawu Morayo Monsurat, and working with National Hospital Abuja. I'm the co-moderator for today. We'll be having 7 presentations, and I will call all of them one after the other. The first presentation is on the effect of propofol and isoflurane anesthesia on post-operative liver enzymes. This will be presented by Dr. Oladimeji Moturayo. The second presentation is on post-open abdominal myomectomy stuttering, a novel experience by Dr. Otokwala Job. The third presentation will be on induction doses of propofol in obese patients undergoing general anesthesia by Dr. Ranusi. The fourth paper will be on severe post-spinal headache treated with oral gabapentin by Dr. Adesina Aderonke. The fifth paper will be on anesthetic management of abdominal pregnancy at 35 weeks for exploratory laparotomy, presented by Dr. Nwoye. The sixth paper will be on palliative sedation in terminally ill patients, a report of 2 cases by Dr. Akinwale Mukaila. He is also doing the 7th presentation, which is on respite case in palliative medicine, case report by Dr. Akinwale Mukaila. So the first paper will be by Dr. Oladimeji Motunrayo. Is she on the call, please? Mr. Didiomi, you can project the presentation. Thank you.
This presentation was not sent. I think it was supposed to present it live.
No, it was sent. The presentation was sent, please. Hello, can you hear me, please?
Let me check, please.
Is Dr. Motunrayo on the call?
Yes, I am here.
Do you have it? If you have it, you can project at your hand too.
Okay.
Mr. Diodomi, you can be checking on your side too. Okay, she has already started screen sharing.
So I'm trying to get back to the screen.
All right, you can be doing that. Mr. Diodomi, the second presentation, start searching for it so that we don't waste much time, please. Is on post-operative, post-open abdominal myomectomy, stuttering.
I have it.
In novel experience.
Eh?
I have it on standby.
You have it now. Can you project it? Please, let's share.
Oh, I mean Dr. Otokwala's presentation.
Okay, you have the presentation ready. Okay.
Yes.
Dr. Oladimeji, go ahead and share your screen from your hand.
I'm trying to do that, please.
All right. Is Dr. Yakubu on the line? Does anybody have a presentation?
Hello, good morning, moderator. Yes, I think some of them, they are already there, isn't it? Dr. Hamisu Yakubu is contacting them.
Can you see the screen now, please?
It's coming on, but we have not seen it.
Okay, maybe we should wait for it.
Open your presentation before you go to share screen.
I've done that.
What I'm seeing is your click on that on your presentation here. When it's open on your laptop before you go to share screen. Mr. Didiomi, you two can be checking if you have it so that it can be faster. Okay, it's open now. Can you go to slideshow? Then it's open on the screen, but all of them are there. Go to slideshow.
I've done that.
Hello, dear moderator. May I suggest that Ejomi should please take over and project this slide since he has it. If these presenters sent their PowerPoint early, this would not happen, and this is what was requested, and this is what is standard in every presentation. Please, can Ejomi take over and project these slides, please? Ejomi, are you there?
I don't have the slide in stock with me.
I thought you said you have it.
No, it's Dr. Job's Otokwala's presentation.
Can we project Dr. Job? I'm sorry, moderator, please. Time is of the essence. Like Dr. Job. Dr. Job, is he there? Can we project his own while Dr. Oladimeji gets ready with her slide sent to Ejomi, please?
I don't think of it.
Please, can you stop screen sharing? Let Dr. Job
Dr. Oladimeji, please stop screen sharing now. Send your presentation to Mr. Didomi. We will start with the Dr. Job Otekola presentation, post-open abdominal myomectomy, stuttering, a novel experience.
Whoever he is, I don't know him, so I'm not going to send it.
Dr. Job, are you on the call, please? Please. Please, Mr. Didomi, unmute Dr. Job.
Good afternoon, great colleagues, senior colleagues, and fellow participants. This part of our presentation is to what looks like a common procedure that is done in our environment. Abdominal myomectomy for uterine fibroids myomectomy for uterine fibroids is a very common procedure in our environment. We know it can actually be done either by open abdominal procedure or hysteroscopic or laparoscopic. So we had an unusual experience because of administering anesthesia on a patient who presented with uterine fibroids that we want to share with us. We call it novel in the sense that it was the first time that we experienced it. We experienced post-procedure stuttering. Stuttering basically means stammering. When someone who has never stammered in her lifetime since she was born suddenly started stammering on the OP table. That was what we wanted to discuss and share this experience with all of us. We have this very short outline. It's actually a case report. Next slides. By way of background is it's very obvious to all of us that surgery is associated with a lot of elicitation of neurohormonal factors. There are a lot of factors that are associated with in the course of surgery, either the pre-aspect of surgery, the emotional drive, and then the surgical trauma itself, and then the post-op management. All these interactions of the preoperative experiences, interpretive factors, all help to affect the cause of surgery. That is one of the reasons why patients tend to develop complications within the perioperative period, which includes the pre, intra, and then the post-op period. And these are things that we need to look out for whenever we have any patient that is on to undergo surgery. And we have different complications that have been documented in literature. Some people end up having pain, some people end up having some emotional imbalances. We are all aware about some people's responses to infection like enteric fever, and they have typhoid psychosis. Psychotyphosis is one of the mental aspects as a complication following an infective process. Well, also, we have also heard about women who have put to bed normally. They had no psychiatric symptoms, but they're not developing people as psychosis. These are all emotional complications that arise from some procedures. So for uterine fibroid, which is a very common a pathology among women of a particular age group, the reproductive age group, and each age group, people who are very sensitive to their reproductive life. Some want to, and there's a lot of issues that I've been read about it. You know, there was a time when going for myomectomy was like having a death sentence. So many persons, very prominent persons in this country, have lost their lives in the course of having a myomectomy, a laparoscopic or open abdominal myomectomy. And there are stories, there are a lot of enigmatic stories around this procedure. Some persons will believe that if I'm going to go for a myomectomy, will it affect my reproductive life? Will I be able to give birth to a child, or will they take out my womb? You know, and this fear is actually one of the reasons why patients tend to still delay to respond to the removal of uterine fibers. So these are some of the initial things that patients tend to, embody as they present for procedures. Every patient is supposed to be seen as a unique person. That's why medicine these days is more of a personalized, event where you look at every person that presents to you and I as an individual, which is his or our own peculiarities. So this patient is a 38-year-old trader who had a huge uterine fibroid. You know, she had no comorbid states. I personally reviewed the patient. She was a lively, jolly, good fellow, you know, who had to come from Lagos to Port Harcourt. Even the mere fact that she had to come from Lagos could have been an indication of what could have probably underlying the reasons why she came. Would it because there are very prominent persons in Lagos, or is it because she's from Rivers, probably she wanted to come back home? And why would she want to come from Lagos to Port Harcourt to do
Hello, Mr. Dijomi, can you hear me? There's no sound.
Yes, ma, I can hear you. I think there is a network issue from Dr. Tokola's end because he's out.
Okay, it's presenting live. I thought there's a record.
I'm hearing you guys.
So can
I'm
you hear
hearing
us?
you.
Okay.
Yes, I'm hearing you. So where did I stop?
Okay, the
Okay,
case
You're on the case
presentation.
presentation.
Okay,
You
yes.
just
So I
started the
said,
case presentation.
okay, we're presenting a 38-year-old young lady who's a trader who came from Lagos with a uterine fibroid, who had prepared her minds over the years amidst the fears of having an open abdominal myomectomy, fears of blood loss, losses of lives. These are stories that abound in our environment. So she prepared her mind, came, and on a preoperative review, there was no problem. The patient was sound. There was not evidence of anxiety. She prepared her mind, and then the initial vital signs didn't show a tachycardia, tachypnea, or any evidence of a stress-induced, evidence that could point out to somebody who was very anxious. So we discussed the anesthesia technique with the patient, and she accepted a combined spinal epidural technique, which has been the standard technique in our team for irrespective of the size of the uterine fibroid. And intraoperatively, the patient was fine. The blood vital signs were all normal, within normal ranges. Blood pressure, there was no blood. The blood loss was about 300 ml. Study lasted about 45 to 2 hours. And then the patient was fine, chatting freely with the team because it was a combined spinal epidural. We didn't give any sedative of any form prior and even intraoperatively. And then suddenly at the end of surgery, when the patient was talking freely with the team, was transferred from the OP table to the trolley. She started stuttering. Stuttering is stammering. The patient has not started stuttering, and then it was usually dismissed. Maybe could be what could have gone wrong. But when we transferred the patient down to the bed, the patient was stuttering. I mean, for hours. She couldn't elicit any good communication. And the driver was like, which drug could be responsible? She had no sedative. There are medications that have been found to actually induce stuttering, affect the speech area. We actually wanted to do a MRI of the brain, but the private facility said there was no need to just watch her. And we checked through literature to find out what could have induced stuttering in a young lady who had no intraoperative adverse events. There was no hypotension, there was no hypertensive episode. The medications were just basically bupivacaine that we had used, both the heavy and the plain, and then we administered morphine for post-op analgesia with paracetamol and diclofenac. So we had to go to search the literature to find out what could have been responsible for this. They said, okay, if you have a problem at the broadcast area, maybe a stroke, but there was no neurological deficits. There was no deviation of the angle of the mouth. There was no evidence at all, except the stuttering. So an initial intention to do MRI was deflected because the facility didn't want it done. But we closed it, and now after a day or the same day when I asked the question, but when we take literature, they said there could be a psychogenic aspects in the causation of stuttering. So then I asked the patients. But then the stuttering wasn't there, but she was managed to now say it. I wanted to play the video, but it's not time to open up. She now said that actually she was very anxious. She had a lot of fears about uterine fibroids, about doing a myomectomy. That we lost some of our friends who died in the course of it. I read books, stories in newspapers about people dying in the course of doing surgery. That she couldn't imagine herself, going for the same things she had so much fears about and coming out without any problem. That fear. So when I heard that aspect and of the psychogenic aspects, and I said, oh, obviously it could be a psychogenic cause of stuttering. And I checked literature whether there was any presentation in the global literature about such an experience as a post-op complication of stuttering. I couldn't find anyone. Maybe some of those in the audience probably have had various experiences. But the stuttering didn't last long. It lasted for 2 days, and everything disappeared. She started talking normally, and the post-op clinical state was normal. So the patient gave us the consent to even take a picture of her with the stuttering, which I was struggling to send it to display it. She said she should go ahead and present it as our own experience. So in conclusion, surgery is known to elicit a lot of perturbations in the patient's physiological states. Some actually affect different aspects. It could be the renal. Some people end up going to wee a couple of times prior to surgery. It could be these are because of factors that are elicited by the emotional drive for surgery. So some persons, like the one we just presented, may end up with a strong psychogenic response, like those of women who have had their experiences of childbirth, having what they call the puerperal psychosis, or those with enteric fever having typhoid psychosis. So we have a patient who now actually stuttered, and then in the course of asking her, she had no family history, she had never stuttered at all in her life. You know, both when she was younger, she was 38, and in her family history. But just this exposure alone to surgery, you know, that was in a very friendly environment. She was fully conscious. That's now presented with this. So this was our experience. So we'll share with our colleagues that we should be aware of it. It could happen. That happened to this patient. It was self-limiting. And then what is the drive home point is, some patients have looked at the literature about the possible medications that can cause stuttering. And then some people said some sedatives can actually give rise to that, in addition to antidepressants, antipsychotic medications. You know, a patient who had no psychotic drive before, if you are giving sedative, maybe would have said, oh, the sedative probably was responsible. But if you had nothing that elicits a sign of anxiety in this patient, and so this developed stuttering, it shows that maybe when we do combined spinal epidural, maybe there was a need for patients to be probably sedated a little bit because of the surgery. Maybe it would have helped to stop it. Maybe it would not help to stop it. Maybe if it's hello, are you hearing me?
Yes, we are hearing you. Please go ahead.
So that is our case reports. Thank you very much. Well, I finished.
Hello. Thank you very much, Dr. Job Otokola, for your presentation. It's actually a novel experience and a very wonderful lecture you've given us. I'm sure there will be plenty of questions on this. Please, let us start chatting the questions in the chat box. Let's start dropping the questions in the chat box. We will now go on to the third presentation. Mr. Didiomi, are you ready with it? Induction doses of propofol in obese patients undergoing general anesthesia by Dr. Ranusi. Mr. Didiomi, please, can you hear me?
I can hear you, ma'am.
Okay, do you have the presentation up?
I've just received it.
Which one is ready so that we can take it? Which one is ready?
Okay, we have one by Dr. Nwoye, anesthetic management.
Okay, Dr. Nwoye, are you on the call? Are you around so that I can take your presentation now while he's preparing the other ones? The presentation by Dr. Nwoye is anesthetic management of abdominal pregnancy at 35 weeks for exploratory laparotomy. Please, you just have 8 minutes. Let's be time conscious, please, so that we can take all the presentations. Thank you. Dr. Nwoye.
Good day, all. I will stand on the existing protocol. My name is Dr. Nwoye Daniel. I will be presenting anesthetic challenges in abdominal pregnancy at 35 weeks for exploratory laparotomy. The following are my core. I will not bother you with. By way of introduction, abdominal pregnancy is a rare form of ectopic pregnancy where implantation of fertilized ovum occurs in the abdominal cavity, sometimes as a complication of normal pregnancy or following in vitro fertilization. The mortality rate associated with abdominal pregnancy is 7 times higher than the general ectopic pregnancy. This presents a major challenge to the anesthesia provider caring for these patients, as most common cause of death are hemorrhage and anesthetic complications. Given the rarity and lack of standard management for this condition, we present our anesthetic of patients diagnosed with abdominal pregnancy who underwent successful surgical delivery of a viable neonate. The patient is a 41-year-old gravida 1 para 0 plus 0 who was booked in a private hospital and was referred on account of ultrasound diagnosis of abdominal pregnancy following in vitro fertilization and embryo transfer for delivery due to paucity of funds and specialist care for the preterm neonate at 35 weeks estimated gestational age. This patient had 26 years history of subfertility from tuboperitoneal factor. During this time, she had 4 laparotomies done. The latest was in October 2020 on account of large right hydrosapping, and subsequently she had sapingectomy and drainage. Precisely in March 2021, she had in vitro fertilization and embryo transfer. She had 3 embryos transferred, after which she had insidious onset of bleeding per vaginum 3 weeks after this transfer was done. This bleeding was described as altered blood, which later became red with associated clots and flesh debris. It lasted for 5 days. This made her to present, during which she had ultrasound done, which confirmed that the uterine cavity was empty. For 3 months, while she was at home, she was experiencing early pregnancy symptoms, vomiting and general body weakness. This necessitated her to present for the second time in the same facility, during which she now had serum PT done and was confirmed to be positive. She now had abdominopelvic ultrasound done, which revealed intra-abdominal pregnancy with a viable fetus at 13 weeks gestation. She started her booking that day, and her booking parameters were essentially normal. The patient was admitted in our facility now as an emergency case at 35 weeks. Reasons being that we were not involved in the initial management. The anesthetic team were not involved in the initial management in the private facility. Our anesthetic plan consisted of general anesthesia with rapid sequence induction and endotracheal intubation, grouped and cross-matched blood and blood product in anticipation of hemorrhage. In the operating theater, baseline vital signs were taken, investigations were confirmed, tranexamic acid was given 1 gram, she was pre-oxygenated for 5 minutes, atropine 0.6 milligram was given as a premedicant, propofol 2 milligram per kg, and intubation was facilitated using 2 milligram per kg of sosamethunium. Tube size was cuffed 6.5 mm endotracheal tube. She had shoulder rolled under her shoulder, and other airway adjunct was made available in anticipation of difficult airway. Anesthesia was maintained using 0.6% halothane in 100% oxygen. Betadine was given intravenously after delivery of the fetus. A midline incision was made, and mother was delivered of a live male baby weighing 2.3 kg with APGAR score of 7 and 9. no gross abnormality. The placenta was attached to the omentum, liver, and large bowel with partial separation in the bowel. There was hemoperitoneum. Hemostasis was secured by applying sustained pressure and suture ligation of bleeding vessel. The patient was hemodynamically unstable during the surgery, and vasopressor was given, ephedrine 20 milligram bolus, and had 2 units of blood transfused perioperatively. The estimated blood loss was 2 liters. The patient received a total of 500 ml of crystalloid and produced 1,010 ml of urine over the 3 hours surgery duration. She was breathing spontaneously by the end of the surgery and was extubated with good tidal volume. Her postoperative pain was well controlled using multimodal analgesia and local infiltration with Privacaine. She was discharged to the ward from post-anesthesia care unit with no significant issues, while the neonate was taken to neonatal intensive care. Abdominal pregnancy is a rare obstetric emergency with limited literature discussing its surgical and anesthetic management. There are 2 types, primary and secondary, although often multifactorial with no clear etiology identified. Common risk factor for abdominal pregnancies ranges from previous ectopic pregnancy to multiparity. It should be noted that patients most commonly complain of persistent abdominal pain or other gastrointestinal symptoms. And of course, clinical signs could be vague. Our patient's main risk factor include history of tubal ablation, in vitro fertilization, and advanced maternity. Fortunately for our patient, this pregnancy was discovered very early and active management instituted. Morbidity and mortality are most commonly due to massive hemorrhage from complete or partial placental separation. Placental separation is highly unpredictable and can occur at any point during pregnancy, causing sudden massive hemorrhage and as well as possible exsanguination and death, both for the mother and fetus. We made the decision to insert large bore cannula in anticipation of hemorrhage. Tranexamic acid was administered as incision and immediately at the onset of bleeding, as it has been demonstrated to reduce mortality from postpartum hemorrhage with minimal adverse effect. In addition, studies have suggested that unless the placenta can be easily tied off or extracted, it may be preferably to leave it in place and allow for natural action. In conclusion, our patient had an excellent outcome of abdominal pregnancy. Blood loss was effectively managed with antifibrinolytic agent. We present this case to demonstrate the comprehensive planning, coordination, and thank you. These are my references.
For your presentation, Dr. Nwoye. Please, Mr. Edidiomi, which presentation is ready now so that we can take it? We are short of time. We still have the first presentation that we've not.
Lecture.
Which one is ready, please?
We have Dr. Rancis' abstract, induction dose of propofol.
Okay.
In obese.
Okay. Please, Dr. Ranisi, are you on the call? Can we have your presentation? Induction doses of propofol in obese patients undergoing general anesthesia. Thank you.
Have it with me.
Okay, please project it. Share the slide. Mr. Didiomi, there's no sound.
The excess accumulation of adipose tissue or body fat is usually classified using the body mass index. The prevalence is highest in America and lowest in Southeast Asia, and prevalence has been increasing worldwide, especially in developing countries. In the southeastern part of Nigeria, the prevalence is 12.3.
The audio of the slide recording is not loud enough. This is the highest.
Let's go ahead. I think we can hear now.
Obesity is the excess accumulation of adipose tissue or body fat. It is usually classified using the body mass index. The prevalence is highest in America and lowest in Southeast Asia, and prevalence has been increasing worldwide, especially in developing countries. In the southeastern part of Nigeria, the prevalence is 12.3.
Mr. Didiomi, we can't hear anything again. Can we have the next presentation if we're having issue with this one?
That's the audio. It's from the recording. I don't know whether she already recorded twice, but that's the loudest.
There's no sound now at all. Please, let's have other presentation. There are 3 more presentations. Which one do you have? Do you have Dr. Oladimeji's presentation now? The effect of propofol and isoflurane anesthesia in post-operative liver enzyme.
Yes, have them.
Let's share it, please. Dr. Oladimeji is on the line. Let's share his slide.
Abstract presentation. The effect of propofol and isoflurane anesthesia on post-operative liver enzymes, presented by Oladimeji Adebukunla. These are the co-authors. It shall be presented under the following outline: introduction, aim, methodology, results, discussion, conclusion. Maintenance of anesthesia is an integral part of general anesthesia, and this can be achieved with the aid of volatile anesthetic agents or total intravenous anesthetic agents. Examples of volatile anesthetic agents include isoflurane, desflurane, sevoflurane, to mention a few. Alloten is well known for its hepatotoxicity. Newer volatile anesthetic agents are supposedly free from hepatic injury. The newer ones are the isoflurane, the desflurane, the sevoflurane, to mention but a few. Isoflurane is commonly used for maintenance of general anesthesia in our institution. Total intravenous anesthesia with propofol during general anesthesia is also on the increase. Propofol, like isoflurane, have been implicated in hepatotoxicity during general anesthesia. This study compared the effect of isoflurane and propofol on liver enzymes following general anesthesias. The enzymes analyzed include aspartate transaminase, alanine transaminases, alkaline phosphatase, and total bilirubin. Methodology. It was a randomized controlled clinical trial that involved 60 ASA 1 and 2 patients that are aged between 18 and 64 years. They were scheduled for elective surgery that required general anesthesia. These patients were allocated into 2 maintenance groups. The group I, received isoflurane at minimum alveolar concentration of 0.8 to 1.5%, while the second group, which is group P, received propofol infusion via a syringe driver at a dose of 100 to 200 microgram per kilogram per minute. Induction was achieved with intravenous sodium thiopental at a dose of 5 milligram per kilogram, and endotracheal intubation was facilitated with atracurium at a dose of 0.5 milligram per kilogram. Blood samples were taken before induction of anesthesia, labeled as H0, in the immediate postoperative period, labeled as H1, and 24 hours postoperative period, labeled as H2. The serum levels of AST, ALT, ALP, total bilirubin were analyzed and compared in both groups. Data analysis was done via SPSS version 23. ANOVA was used to analyze changes within group, while independent t-test was used to compare changes between groups. The results. It was observed that the two groups are comparable in both demographic and clinical characteristics, except for duration of anesthesia, which was longer in the isoflurane group and with the p-value of 0.00. It was observed that propofol caused a reduction in ALP with a p-value of 0.005, but an increase in total bilirubin with a p-value of 0.010 by the end of the study. Isoflurane had non-significant changes within the group. ALT, ALP, and total bilirubin were comparable between groups throughout the study. Only the mean ASC values in the isoflurane group was significantly higher at 24 hours postoperative period with a p-value of 0.0. Our study supports the knowledge that anesthetic agent cause changes in liver enzymes, but to a varying degree. Propofol caused a significant decrease in ALP at the end of our study, while total bilirubin rose significantly at the immediate postoperative period but declined after 24 hours, though it did not return to baseline. Isoflurane, on the other hand, produced non-significant changes in all of the liver enzyme and anesthetic agents and types of surgery may contribute to postoperative hepatic injury by various mechanisms. Majority of anesthetics cause a decrease in portal blood flow associated with decreased cardiac output, while hepatic arterial circulation may be preserved, increasing. If the hepatic arterial flow increases but is not sufficient to compensate for the reduction in portal blood flow, then total hepatic blood flow is reduced. This may result in reduction in clearance of endogenous and exogenous metabolites with high blood extraction ratio like propofol, thus the possibility of a cause. Alkaline phosphatase usually increases in cholestatic disease, and values of 1.5 to 3 times the upper limit of normal are consistent with hepatocellular causes, e.g. viral infection, drug toxicity, and alcohol. Low levels of ALP can be found post-cardiac surgery in patients with heart failure and patients with zinc deficiency. Propofol has been documented to cause a reduction in serum zinc in the postoperative period, as well as a reduction in alkaline phosphatase, which may thus be interrelated. Though we demonstrated a significant fall in alkaline phosphatase levels in the propofol group at the end of the study, none of our patients exhibited values outside the normal range. Other researchers have also noted this. The reduction in alkaline phosphatase may be related to the dose of propofol employed, as Kim and Song, who employed a lower concentration than ours, found no change in alkaline. We observed that mean alkaline phosphatase levels in our isoflurane patients remained relatively stable throughout the period of study, though 5 patients had values greater than the upper limit of the normal range of 40 to 150 units per liter. Despite the decrease in the level of ALP observed in the two groups, the observed differences were comparable between the two groups, with a p-value of 0.03. Bilirubin is elevated in liver parenchymal dysfunction and cholestasis, which is the basic pattern in drug-induced liver injury. In our study, propofol caused a significant increase in the serum total bilirubin level immediately post-surgery, but this returned to near baseline after 24 hours. Propofol increases hepatic and portal blood flow. Thus, hepatic ischemia from reduced blood flow found in other anesthetic agents is not expected. Propofol. On the other hand, propofol has a mean clearance of 2.2 liters per minute, which is greater than total hepatic blood flow. It is therefore possible that it accumulates after prolonged infusion. Where patients were exposed to more than twice the propofol infusion time as in our study, Dabiri et al. Recorded a significant increase in total bilirubin even at 24 hours postoperatively. This suggests that the duration of propofol infusion is a risk factor for development of significant changes in bilirubin. In our isoflurane demonstrated by minimum alveolar concentration 2%. Aspartate transaminase is elevated in liver parenchymal dysfunction. It could be normal or reduced in advanced stage liver disease. It begins to rise after 8 hours and reaches its peak at 24 to 36 hours. Liver damage. Isoflurane caused a progressive increase in the serum level of AST during the study period. This increase was more than the upper limit of normal in the immediate postoperative period and 24 hours postoperative period. The difference in the mean value was, however, not significant. A maximum increase of 22.4% was much less than 89% noted by Kim et al. And 168% by Dabil, both of whom documented longer duration of we did. Decline in AST levels varied in both studies. While Kim had a return to normal values by 72 hours, Dabil still documented higher values at 72 hours. We are unable to verify this as our study period was restricted to 24 hours postoperative period. The higher increase in AST found by Dabil might also be due to rhabdomyolysis as a result of prolonged lateral decúbitors position. However, all surgeries in our own study were done position. Though the serum level of AST decreased progressively throughout the study period in the propofol group, the difference within the group was not significant. This is similar to results of other researchers. Our study revealed that it was only at the 24-hour sample that AST levels differed significantly between the fluorine and propofol group. Alanine transaminase, which is the traditional biomarker of hepatocellular damage. Values greater than 500 units per liter are observed primarily in diseases that affect hepatocytes such as viral hepatitis, toxin-induced liver damage, and ischemic liver injury. We demonstrated insignificant changes in alanine transaminases in both study groups, which suggests that hepatocellular damage did not occur in our patients. Other researchers have recorded differing results, which may be a consequence of dosage or concentration, duration of anesthesia, study population, and type of surgery. In conclusion, isoflurane and propofol had varying effect on liver enzymes, but the observed differences were comparable between groups. Both agents can be safely used in improving liver.
Okay, thank you very much, Dr. Oladimeji, for your work. We will now take the other presentation. Please, Mr. Didomi, play the other presentation in this order. Severe post-spinal headache treated with oral gabapentin by Dr. Adesina. Then after that, we take the other two papers, palliative sedation in terminally ill patients, a report of 2 cases by Dr. Akinwale. Dr. Akinwale will also take the second paper on palliative medicine, respite care in palliative medicine, case report. The same Dr. Akinwale that will also take it. Mr. Didomi, please play, share the slide for these 3 presentations after the order to save time. And afterwards, my co-moderator, Dr. Nkechi, will take the question and answer section. Thank you.
Good morning. I'll be presenting post-spinal headache treated with oral gabapentin. My name is Dr. Aderonke Adesina. Spinal headache or post-dural puncture headache can be quite distressing for the patient, giving the patient an unpleasant postoperative period and a prolonged hospital stay. 0 to 10% follow spinal anesthesia, while up to 81% follow accidental dural puncture while trying to institute an epidural. It results from CSF leakage into the epidural space via a tear in the dura. This results in decreased intracranial pressure and a downward traction on pain-sensitive intracranial pressure structures. Post-dural puncture headache may be associated with more ominous other complications like subdural hematoma, seizures, cranial nerve pulses, sagittal sinus thrombosis. Its management includes a detailed history, examination, relevant investigations to rule out differential diagnosis. This could be vascular, like migraine, or subarachnoid hemorrhage, infective, like meningitis or encephalitis, a space-occupying lesion, pharmacologic or metabolic, like caffeine withdrawal and dehydration, and others like tension headache, benign intracranial hypertension, and hematocephalus. As we all know, post-dural puncture headache resolves spontaneously in most situations, but not every patient who does not respond to traditional management modalities will require an epidural blood patch. Invasive procedures like epidural blood patch and sphenopalatine ganglion block are not without challenges, especially in environments with limited resources like ours. A consideration should always be given to unconventional pharmacologic agents. Our aim was to highlight the importance of considering other classes of drugs in the management of spinal headache and to show that oral gabapentin may be useful when traditional analgesics for spinal headache fail. I present a 41-year-old female who was scheduled for inguinal mesh herniorrhaphy under subarachnoid block. She had a BMI of 23, an ASA status of 1. All preoperative investigations done were within normal limits. There were multiple attempts at instituting the subarachnoid block using a 24-gauge Quincke needle at the L3-L4 space with the patient in sitting position. 3.8 mils of 0.5% heavy bupivacaine was injected into the subarachnoid space. All the entire period of the intra and immediate postoperative periods were uneventful, and the patient was discharged the first day post-op. On the second day post-op, she developed a severe throbbing frontal and occipital headache radiating to the neck, which was worse on standing, necessitating staying in bed all day. She described the pain as the worst pain ever. We started her on initial conservative management with oral hydration, oral paracetamol, ibuprofen, caffeine, and cocodamol, and the coffee and some coffee intake with no relief. By the third day post-op, oral caffeine was increased to 30 milligram, 300 milligram, and was, but this did not give the patient any sustained relief of symptoms. On the first day, oral gabapentin was instituted and was prescribed to be taken at 400 milligrams TDS thrice daily. There was a marked relief of all the symptoms within the first 12 hours. Gabapentin is a serotonin agonist that binds alpha-2 delta type voltage-dependent calcium channels. It's being used as a popular anticonvulsant. It decreases the stimulated release of transmitters. It has been useful in the management of epilepsy, neuropathic pain, and as a primary therapy or analgesic adjunct for post-dural puncture headache, especially in patients unresponsive, even in some patients unresponsive to epidural blood patch. In a study conducted by Wagner et al., 17 obstetric patients were observed to have an excellent, they studied 17 obstetric patients, and an excellent result was observed in 9 of those patients within the first 24 hours of instituting treatment with gabapentin. In another study by Honor and colleagues, they carried out a review of 13 small random control trials, which involved 479 participants. They were reviewing the drug therapy for treating post-dural puncture headache, and they observed that gabapentin results in better visual analog scale scores after 1, 2, 3, and 4 days when compared to placebo. We noticed this marked improvement in our patient within the first 12 hours. Oral and intravenous caffeine have also been recommended, but there have been reports of recurrence, and these have been documented in literature. Also, reports have, this was also reported in our patient, and some obvious side effects that are quite undesirable include insomnia, arrhythmias, and seizures as a result of the use of caffeine. Some other drugs have been used in the treatment of postural puncture headache. This include, like we have said previously, paracetamol, NSAIDs, and corticotropin analogs, and some other serotonin agonists like theophylline and hydrocortisone. Recently, atropine and neostigmine have been studied. They are said to cause cerebral vasoconstriction and increase the CSF production, thereby reducing the headache. Gabapentin was studied versus ergotamine caffeine, marketed as Cavedoc, was studied by Errol and co-workers, and they investigated the analgesic and the antiemetic effects of these drugs. The severity of headache and vomiting episodes were compared in 42 adult patients. They noticed that the results for the gabapentin group was significantly better. We used a combination of PCM, ibuprofen, caffeine, marketed as Ibex in our patient. In another study by Mahori et al., they went on to investigate 90 patients who were randomly grouped into acetaminophen, gabapentin, and pregabalin groups. They compared the VAS scores at 24, 48, and 72 hours after the onset of the headache. They observed that the pregabalin group had a higher, a more excellent result compared to the gabapentin group, and the gabapentin group had a more excellent result compared to the acetaminophen group. They also observed no major adverse outcome in the use of these drugs. In literature, pregabalin has been associated with severe allergic reactions and even suicide ideation in some patients. This makes it less desirable. Then in another study by Harvey and colleagues, gabapentin, this popular anticonvulsant and oral non-opioid analgesic, was used prophylactically. They gave 300 milligrams at 1 hour before surgery, then 12 hours for 24 hours after. They randomized 120 patients into these two groups, the gabapentin and placebo groups. They observed a real reduction in the incidence of post-spinal anesthesia headache and an improvement in the postoperative pain and morphine consumption without any significant difference in serious adverse effects in the gabapentin group. We administered 400 milligrams twice daily in our patient. Common side effects of gabapentin like drowsiness, tiredness, dizziness, tremors, blurred vision were not reported by our patient or any of the previous researchers. In conclusion, post-dural puncture headache is a common complication of spinal anesthesia. Various drugs and formulations have been used in the management of post-dural puncture headache with varying degrees of success. Oral gabapentin has been shown to be effective as a primary therapy or as an adjunct in the management of severe post-spinal headache. Gabapentin should be considered in cases not responsive to traditional analgesics in the treatment of spinal headache before resorting to epidural blood patch. More research into the use of gabapentin for post-dural puncture headache is required. These are my references. Thank you very much for listening. I'll take questions.
Hello,
Thank you.
hello, madam.
Thank you. Okay. Thank you, Dr. Ronke, for that beautiful presentation. We'll now call on Mr. Idiomi to share the remaining slides, the next presentation. Thus, we have knowledge and attitude of women towards labor, epidural analgesia. That's Dr. Bikis Mohammed. The slide ready, Mr. Idiomi?
Yes, it is. I'm on it.
Thank you very much. Then the next presenter is palliative sedation in terminally ill patients, a report of 2 cases. I don't know if Dr. Akinwale is on this call. And he has another paper, the respite care in palliative medicine case report.
Can I play Dr. Bikli's presentation now?
Yes, please do. Thank you very much.
And attitude of women towards labor, epidural analgesia. The authors here are Hassan Maina A, Bakari M.A., Muhammad Bilkis, Badla A.M. of Department of Anesthesia, FMC Yola, Department of Obstetric and Gynae, FMC Yola, Department of Anesthesia, ABU Teaching Hospital Zaria, and Department of Anesthesia, ATBUTH Bauchi, respectively. The table of content are background, methods, results, conclusion, tables 1 to 3, and figures 1 to 2. Background here, we know the women of childbearing age will experience labor pain while delivering their babies. Most of those deliveries occur without pain relief and women have to endure. This study is to assess the knowledge and attitude of women towards labor epidural. We had a total of 198 women attending the antenatal clinics of Federal Medical Center Yola and Adamawa State in northeastern Nigeria. The interview was done using semi-structured researcher-administered questionnaires. Respondents' social-demographic characteristics, knowledge of epidural analgesia and its acceptance were obtained and subsequently analyzed. Among the 198 women that responded, 9.1% were less than 20 years of age, 3% were between 41 and 45 years. All respondents were married except one. 30% were nulliparous and only 4% were multiparous. 4% of them had no formal education, 1.5% had primary education, 39% had secondary education, and 56% had tertiary education. Islam was practiced by 63% of the women, while 37% of the women were. 27% of the respondents were civil servants, and students made 18%, while others were housewives and traders. Labor pain was experienced by 67% of the women, and 25% of them said it was mild, moderate in 40%, and severe in 30%. Pain relief in labor was known by 32% of the women, and 17% knew through the antenatal clinic, while 9% from doctors. Other means were through the internet, friends, and 48% of women were indecisive about willingness to receive epidural analgesia, 28% were not willing to receive, and only 23% were willing. For those who were unwilling to receive, 17% of them stated lack of awareness as reason, while 8% deemed it not necessary. A few cited cost of epidural, 7% said it may be harmful, and 67% of women had no reason. Labor epidural analgesia has been received by 27% of the women, and only 25% of them would recommend it. This study has shown that there is a poor awareness and acceptance of epidural analgesia in labor in this environment, which will be greatly improved by public enlightenment and counseling during antenatal. The table 1 we have shows the age, demography, frequency, and percentages, which range from less than 20 up to 40. The table 2 shows religion, frequency, and percentage, which includes Islam, Christianity, and others. Table 3 shows the severity of pain, which is mild, moderate, and severe, with frequency. Figure 1 shows how pain relief in labor was known in percentages through antenatal clinic doctor, while Figure 2 shows the reason epidural analgesia will not be accepted due to lack of awareness, not necessary, costs, may be harmful, and no reason.
Mr. Ediomi, we seem to have lost the
That's the
video,
end of the slide,
please.
ma'am. That's the end of the slideshow, ma'am.
Oh, okay. Thank you very much. Do we have Dr. Akinwale here? The next presentation is by Dr. Akinwale, the palliative sedation in terminally ill patients, report of 2 cases. Then the other one still by Dr. Akinwale, respite care in palliative medicine, a case report. Please, can we have the slides?
Hello? Hello?
Yeah, okay, yes, we can see the slides. Thank you very much. Please, you can start the presentation.
Can you hear me?
Yes, you have
Hello?
8 minutes, please.
Okay. Good day, ladies and gentlemen. My name is Dr. Akinwale, and I'm presenting 2 cases of palliative sedation in terminally ill patients. Next one, please. Next. Okay. Well, as we all know, in the last days, hours of life, patients who are chronically ill or terminally ill, they do undergo degrees of devastating symptoms. And this will include physical and psychological distress, such as delirium, agitation, anxiety, restlessness, pain, and so on. And as we all know, the main aim of palliative care is to improve quality of life, thereby providing comfort at each stage of disease, the individual suffering from terminal illnesses. According to the European Association of Palliative Care, palliative sedation is defined as the mandatory use of medications intended to induce a state of decreased oxygen awareness in order to relieve the burden of otherwise intractable suffering in a manner that is ethically acceptable to the patient, to the family, and healthcare. So to conduct palliative sedation has to be ethically acceptable practice when used in appropriate situation. And so therefore, the main aim of sedation is to reduce unbearable stress when other measures are failed. So I want to use these 2 cases to educate us on the use of palliative sedation to alleviate suffering in our patients who are critically ill. So the first one is a 60-year-old man diagnosed with an carcinoma of the lung. He has been on a palliative care for symptom control for about 3 years. When he was deteriorating, he was admitted to, for end-of-life care. And on the 4th day of admission, he became very agitated, restless, dyspneic, was moaning and groaning. And was death rattle due to accumulation of secretion in the airway. So the family members and they were very disturbed and were frightening. So we had to cancel them on the end-of-life care and then the need to commence palliative sedation. So we also obtained informed consent from them. Next, please. Next slide, please. So we commenced an intermittent sedation via subcutaneous cannulation. And drugs that we used to include midazolam, 2 mg start, and then which was increased to 4 mg PRN. The morphine was given at 1 mg start, then 4 hourly, then increased to 3 mg, and then PRN. The aliperidol was also given at 2 mg start, and then PRN. Then to control the death ratio due to secretion in the airway, we also give algopyrrolate at 0.2 mg start, then PRN. Then give oxygen and we monitor with NIBP, pulse rate, saturation score. In palliative care, we commonly use Richmond agitation score to monitor the patient because it can be used for both agitation and sedation. So after 30 minutes of the sedation, PM became calm and passed on peacefully after 6 hours of sedation. Next, please. Then, second patient that is also a 60-year-old man diagnosed with the cancer of the prostate with mets to the brain, liver, and the lumbar region. He was palliative care for about 2 years before it started deteriorating, and he had to be admitted for end-of-life care in the hospital. So, on account of the severe restlessness, agitation, panicking, it was commenced on the palliative sedation with morphine, midazolam, and aliperidol in appropriate doses, which were titrated to effect via injection. It was monitored with the NIBP, oximeter, pulse rate, and sedation score. And it became tranquil and calm and was on this regime for about 7 days before he passed on peacefully. Next, please. So these 2 cases illustrated the type of distress that our patients who are at the end of life go through. So, and the European Association of Palliative Care, they developed a framework in which they lay emphasis on titrating doses of sedation against symptoms, and if possible, to maintain awareness. So in palliative medicine, the sedation you can use Richmond's sedation score, which can be mild, intermediate, or deep. And depending on the duration of sedation, it can be intermittent or continuous. But either we use intermittent or continuous, we have to focus on 3 things in sedation. The first is first, what is the effect of sedation on the quality of life of the patient? And 2 is that how peaceful and comfortable is the patient during the dying phase? Then 3, how well sedation control the symptoms that are troubling the patient? Next, please. The terminal restlessness is an agitated delirium that occurs some people the last day of life. And there have been many studies which try to report the common stress symptoms to patients when they are at the end of life. According to Lin et al., they indicated that in the last 3 days of life, 80% of dying patients had severe fatigue, 50% had severe dyspnea, and 40% had severe pain. The Hickman et al. Also saw that at the end of life, commonly reported symptoms were fatigue, dyspnea, and dry mouth, but the most distressing one are pain, fatigue, and dyspnea. Also, Cohen et al. And Morita et al. Report that the most stressing symptoms were excessive breathing, excessive respiratory secretion, agitation, anxiety, and so on. Next, please. So, in palliative medicine, just like any other branch of medicine, there are many drugs that can be used for sedation, and each hospital or each hospice care has its own protocol. In the place where this was done, the commonly used drugs are particularly midazolam. Antipsychotic like aliperidol, opioids like morphine, and if available, we use a propofol. So they can be given intravenously or subcutaneously. And one thing about sedation is about the fear by the families and some physicians on the issue of sedation versus euthanasia, and co. But it is shown that the palliative sedation does not hasten death when compared to people who are not sedated. Next, please. So, in conclusion, in terminal phase of life, when symptoms become refractory and can be controlled by any supportive or palliative therapy, palliative sedation therapy is one potential solution to providing relief for the patient. And as doctors, we have fundamental ethical responsibility to ease suffering, particularly when intolerable distress occur in those who are end of life. So, thank you very much. Can you show my references, please? Thank you very much.
Thank you very much, Dr. Akinwale. Now we'll go over to his second presentation, which is titled Respite Care in Palliative Medicine, a Case Report. Thank you very much, Dr. Akinwale. You have the floor again.
Good day again. Presenting the second case report, which is a respite care palliative medicine. Please, next one, please. Next slide, please. Well, at one point in time, any point in time, in our life, we've all, each of us must have taken care of our sick loved ones, either actively ill or chronically ill. And we know that taking care of people who are sick can be burden, can be stressful. So caring for individual stability of life-threatening terminal illnesses places an burden on the caregivers. So in palliative medicine, in palliative care, we have former carers and informal carers or caregivers. The informal caregivers are the family members, relatives, Can you please remove the thing, please? Can you please stop the hello, please? Can you mute the please?
You want to do assignment?
Okay. And they are
hello.
I think you can do.
Please,
can you hear Dr. Akinwale?
Please. Dr. Akinwale, can go on.
Go back, please. Go back, please. Go back. One slide back, please. Can you go back, please? As I was saying, respite care is born out of a necessity to provide a respite or a break to the caregivers. And by definition, respite care is simply provision of a temporary break in caregiving activities for the informal carer to reduce stress and promote well-being. And oftentimes, as carers, for those who are chronically ill, we do experience challenges in maintaining physical and psychological health, and also maintaining financial and social well-being. So I want to use this case report to illustrate the benefit of respite care and options available to our patient. Next, please. Next slide, please. So it's a 30-year-old man with traumatic quadriplegia and belt sore over the left thigh. The man sustained injury to the spine 14 years ago and has remained bedbound since. His main carer or the main caregiver is the only young brother who is a 25-year-old apprentice, and their parents have a disease. So it depends virtually on the younger brother for feeding and other essential of daily living. So it requires manual evacuation of a stool alternate day and bladder catheter change monthly. So, and he normally comes for admission once in 3 months at inpatient of the administration of the hospital to give his brother a respite or break, so as to allow him to pursue his own business. Next, please. As I said earlier, in palliative medicine, we deal with patients who are chronically ill and have less remittance. So in our effort to provide comfort and improve quality of life of these patients at the end of life, the informal caregiver and family members pass through a lot of distress, and this is commonly referred to as a caregiver's burden. Caregiver burden is an all-encompassing term which refers to physical, emotional, financial impact of caring. And according to the European Association of Palliative Care, recommend that there must be a respite facility to alleviate caregiver distress. So therefore, the aim of the respite care is to change the well-being of the caregiver and also the care recipient. Next, please. So, what are the impacts of caring on caregivers' health and well-being? First, when somebody is taking care of a chronically ill patient, is physically trained, complain of illness, complain of muscular problems, and so on. Also, emotional strain, they have anxiety, anger, depression, short temper. Some are very, very aggressive to the recipient and also lead to stress. Also, they have financial strain, which can be direct or indirect, which has reduced income and increased spending. Socially, they cannot interact with, they cannot interact socially and lack privacy. Some complain of disturbed sleep and poor appetite. Next, please. So, to give respite care, there are many, some forms that we can use. But the common one is inpatient care, in which beds are designated, either a specialist medical unit in the hospice or dedicated beds in the hospital, where people can stay for one or two weeks or more. We also have a day care, which can be adult or pediatric, and also we have home-based care. In home-based care, the healthcare professionals who are trained in palliative care or volunteers, they go to home of the patient, take care of the patient for a few hours or days. We also have a community-based palliative care, in which in some countries where they have community palliative care, the trained carers or volunteers can go to the home of the patient and the community and then take care of the patient for a few hours or days. Because we have a short-term or long-term respite care. For short-term respite care, just for system control or to give the caregiver a break. For long-term, it's just for terminal care. It can also be planned for emergency. Then we have a paid and free respite care. The paid one can be done by a trained nurse or trained lead male or women. But for free one, it's only done by the trained volunteers. So next, please. So what are the advantages of respite care? First, it provides a break for the caregivers so that he can pursue his own personal businesses. Also, it provides opportunity to review health of the patient and the caregiver. Also, it provides valuable interaction and access to leisure facilities, and also provides peer support and sibling support. Next, please. So, what can be provided by bodies such as voluntary services. We have NGO that can provide that can have if they have facilities that you can do respite care, can be done through those services, and in a foreign country, can be done through NHS, Medicare, or Medicaid in America. So please, next please. In conclusion, respite care can be regarded as a form of social support, which aims to improve the caregivers and care recipients' satisfaction, thereby reducing emotional and physical distress. It also allows family caregivers to relax or have a time out from caregiving work regularly or in a situation. Thank you very much for listening. I'll take the questions.
Thank you very much, Dr. Akinwale, for those brilliant presentations. Thank you. So I don't know, is there any other slide that you have not taken, Mr. Idiomi? Is there any pending presentation you've not taken?
Not sure. Please, have you taken Dr. Oranusi's lecture? I think.
No.
Okay, let me fetch it.
So our next presentation is the induction dose of propofol in obese patients undergoing general anesthesia. And this will be taken by Dr. Oranusi. I hope she's on this call so she can take the notes of questions in the chat box. While the slides are playing, we our practitioner, please prepare the summary of all the presentations so we can have a summary and have a better understanding and insight into these beautiful presentations. So Mr. Idiomi, please can you project Dr. Oranusi's presentation? Thank you very much.
Oh, this is a presentation that was having audio issues. The volume was very. Please,
Can you just run through it? Is it, we can take maybe the part we have not taken. Was there any improvement in the sound?
No, the second edition sent to me is still the same way. So if she's here, she can actually present it live while I run the slides.
Okay, okay. Do we have Dr. Oranusi on this call? Or maybe the other co-authors of this paper, that's Ezima, Evaristus. So Mr. Idiomi, you can play the slides.
Hello. Hello.
Hello, ma.
Hello, ma.
Madam Moderator, what is happening?
Okay, we noticed that there is no audio. We're just wondering if we could play through the slides in case she's able to maybe respond to some questions. But if she's not on the platform, I think we'll discontinue this so we can move ahead.
It has been on discussion for a long time before I talked to you because the slides were not moving.
Okay. So thank you very much to for the presentations. Thank you all the presenters. I think Mr. Idiomi, you can make some of them co-hosts so they can respond to their questions. We have some questions on the chat box. Please note your comments and then chat there, or you can raise your hand for recognition. I don't know if we have, we're supposed to have a repertoire. Dr. Mu Cheziada, are you still available or?
I will be rapporteuring for this session.
Who?
Bilkis Muhammad.
Oh, okay. Thank you, Dr. Bilkis, for taking up this role. So I will invite Dr. Bilkis Mohammed to give us a summary of all the presentations so we can catch up on them and have a resounding memory of the presentation that have been done this afternoon. Dr. Bilkis, you have the floor. Thank you very much.
Okay, thank you very much, Ma. This second science session of the scientific activity started 11:56 a.m. Lasted a total of 1 hour, 25 minutes. There was initial glitch, which was overcome, and presentation of 5 case reports and 3 studies were made successfully. The first was that taken by Dr. Joe Botokwala on post-open abdominal myomectomy, and the novel experience of stuttering, which was reported to have subsided within 72 hours of surgery. This was followed up by the presentation on severe post-spinal headache that was treated with oral gabapentin, anesthetic management of abdominal pregnancy at 35 weeks for exploratory laparotomy, palliative sedation in terminally ill, which was a report of 2 cases, and respite care in palliative medicine, also a case report taken by Dr. Akinwale M.O. There was another presentation on epidural analgesia, knowledge attitude of women towards labor epidural analgesia in northeastern Nigeria, in which the finding was such that there was poor knowledge and there was need for subsequent enlightenment on labor epidural analgesia. The effect of propofol and sevoflurane anesthesia on postoperative liver enzyme was also taken by Dr. Oladimeji Motunrayo. Unfortunately, we're unable to take the presentation on the induction dose of propofol in obese patients undergoing general anesthesia due to poor audio. Summarily, this was what we had in this session. Thank you very much.
Thank you, Dr. Bilkis Mohammed. Thank you for the very brief and concise summary of the presentations. Now we are going to move to the chat box to see the comments and the questions that we have there. Now the first comment is from me, that's Dr. Koje. He said, did this patient have an EEG? So maybe assess the, I know the Dr. Job on this call. This is a question related to your presentation. There are another one, that's from Dr. Odukeye Rukewe. Okay, this is from Ogara Teaching Hospital. Is it possible that the patient may have experienced some signs of local anesthetic toxicity? It's asking you, that should be to Dr. Tokwala too. Then again, another person, okay, Dr. Job responded. He said he wanted an MRI or CT scan to rule out stroke or embolism from the epidural, but this was not done. couldn't be done. Then again, Dr. Duke is asking, please, is it possible that the patient may have experienced some CNS signs, that's central nervous system signs of LA toxicity? Could this be the result of the stuttering? Dr. Jogo, you are noting your questions. Okay, he responded that the EEG will depict normal active neural activity. This is now again from Dr. Duke. He says some other signs that can be seen in a case like this could include extreme talkativeness, staring into thin air, and seizures. Then Dr. Job responded that LA toxicity cannot isolate the Broca's area and the cerebellum without other signs. Dr. Job responded that for combined spinal epidural, he often uses 15 milligrams of bupivacaine for the spinal components and top up with plain bupivacaine at 10 mils through the epidural space. Where placed catheter without evidence of migration, no blood in the catheter or filter can cause toxicity, or cannot be a cause of toxicity. That's what I tried to write there. This is another question from me to the presenter of the intra-abdominal pregnancy report. Is atropine routine pre-medication in obstetrics? Because we noted that you use atropine. Then Dr. Yunusa Yusuf is asking a question for Dr. Wonye. He said, how did you give the 20 milligrams of ephedrine? Okay. This is a comment. There have been reports of loss of speech and stuttering in cases in the literature. So maybe Dr. Job will also comment on that. Then is the dose of 3.8 mils not too high for an inguinal procedure? That should be directed to Dr. Aderonke, I'm sure. And how available is gabapentin in our environment? Maybe some people may want to find out how they can get the drug since it's novel. Then this is from Dr. Ado Ahmed. He said, since for the first 3 days, you are doing conservative management with hydration, ibuprofen, and caffeine, how sure are we that the introduction of gabapentin are involved in marked reduction of the symptoms? How are you not sure? How did you exclude this, that is not from your conservative management? Then Dr. Owuda to Dr. Aderonke, was gabapentin used alone or the other drugs were continued with gabapentin use? Then this is from MI phone. Please rename your devices so we can know the people that are asking questions. He said your use of gabapentin on the 4th day is borderline on whether it helps as a natural history of PDPH is from 72 hours to 1 week. It will be interesting to see your study as a case control with a higher level of evidence. In all, it's a great case report. Then this is from Dr. Olatubunsi. Well done, Dr. Ronke. A game changer is here. It's a question. Then this is from Dr. Olanike Ademwa to everyone. Thank you for your presentation. Could you please shed light on the choice of 324G spinal needle and 3.8 mils of 0.5% heavy marking? I'm sure it's a follow-up of the other question. Again, this is from Dr. Aderonke to everyone. Tablets of gabapentin is available in Lagos. I'm sure it is available on request across the country, as it is being used fairly commonly for chronic pain. Your use of gabapentin on the 4th day is borderline. This is from, again, MI phone, on whether it helps as the natural history of PDPH is from from 72 hours to 1 week. It usually starts on the 4th day. It will be interesting. Okay, that's a repeat. There are modifications to sphenopalatine ganglion blocks techniques that are patient-friendly. Good job, Dr. Akinwale. This is from Dr. Tonia. Your submissions regarding respite care are on point. The multi-center study we concluded recently on respite care for family caregivers of cancer patients aptly captures these issues. This is from Dr. Shinyo Aderonke. In our environment, more expertise is required for epidural blood patch and sphenopalatine blocks. So these less invasive alternatives should be explored. Thank you very much. I think at this juncture, we'll pause with the chat box. There are some hands up. We have Madam President hands up and Dr. Babatunde Oshinaike. Please, Madam President, you have the floor. Thank you, ma'am.
Thank you very much, the moderator for the day, Dr. Koje. Thank you for the nice piloting of the session. I want to thank all the presenters. I congratulate them for their presentations. My comment, is it a comment or a question, is to Dr. Job Otokwala. I wanted to ask if the periods or the times of stuttering were recorded or videoed,
Yes,
so that
yes,
it can be
I videoed it.
okay,
Yes,
so
ma'am.
that we could
I'll forward it to the house. I'll forward it to the house.
Okay.
I will try to use to forward
Okay.
it since it's not connecting.
Okay, then the other thing I wanted to say, and somebody also mentioned it, is that you may have to refer the patient to a neurologist or a speech therapist. I don't know, because if a surgical procedure can trigger something like that, that it means it could have been a very traumatic experience for the person. That's my comment. Thank you.
Thank you, Madam President. That was very brilliant. We now call on Dr. Babatunde Oshinaike. We can see your hand up. Thank you, sir. You have the floor, sir. Please, Mr. Idiomi, can you unmute Dr. Babatunde Oshinaike, please, so he can make his comments.
Thank you very much, the moderator, for this opportunity.
Thank you, sir.
I want to thank the presenters for the excellent presentations. I'll be giving general comment about the presentations so far and one or two specific comments. I want to particularly say I've enjoyed most of the presentations, but especially the presentation by Dr. Olademeji, propofol and isoflurane on the liver. I want to say this is quite an excellent study. It's an excellent work, which is, I want to say, to be sincere, is one of those I've enjoyed so far in our scientific sessions. So I want to congratulate on for that presentation. I just want to add that the picture you found, because your conclusion is like you feel that these two drugs can be safe in patients with liver disease or so, but the picture might be different in patients that I didn't notice the group of patients you used, but in patients with liver disease, I think we can't be sure what we're going to see in such patients. But I want to say I enjoyed your presentation. Also, a comment about Dr. Bilki's presentation. When you are presenting a paper like this, I expect it to be more standard, because I don't expect you talking about the figures and the tables after you've talked about conclusion. Okay, so it's better you arrange your slides in such a way that you talk about tables and figures are under results, shouldn't be coming after the conclusion. So that is important, just to note that. And generally, I want to say that I know NSA is a trial ground or is a preparatory ground for us to present. But we must bear in mind that this conference is being watched by others who are not even in Nigeria, other groups of people. We are streaming on on YouTube. So we must ensure that our presentation, as much as possible, are up to standard, are quite standard in terms of how the slides are presented and how we even deliver our presentation. That's just a general comment. Thank you very much.
Thank you very much, sir, for your comments. I don't know, Dr. Job, can you respond to some of the questions since you're available?
I thought I've responded to most of the issues on the chat box. Like somebody said, could it be LA toxicity? And we all know the clinical signs and symptoms of LA toxicity. We will have administered a medication 2 hours after. You're now having stuttering as a sign of LA toxicity. Anything is possible in medicine, but there are risk factors for possible toxicity. But I believe you give an overdose, or if you inadvertently administer your medication through the intravascular routes. None of these, were observed in the course of the procedure. The dose we usually use for abdominal myomectomy was 15 milligrams, and then the top up was just 10 milligrams. There was no evidence that the catheter was in a blood vessel. So we actually tried to define what could have been the causation of stuttering. That's why I wanted to do MRI immediately. EEG is a bogus machine to be brought into, the facility didn't have that. If we had that, we could have just done that. But there was an obvious stuttering that was not there. Either childhood or prior to procedure, it was noticed on the patient was being moved out of the OR. So that was the reason why we tried to narrow down to psychogenic cause. And when we asked the patient, and the patient now confirmed it, that she thought she would be able to survive it, the intensity of the anxiety and the anticipation of what could be the outcome at the end of the day. So that's how we narrowed down to that. And then there was no other neurological deficits. Stroke is another thing that can actually give rise to stuttering. You have intraoperative stroke, you can have stuttering. That was one of the drives for a CT or MRI. We didn't have that. And the thing lingered for just 2 days. By the second day, the patient was completely normal. Could be a transient TIA. If it's transient TIA, there could be risk factors. So what could be the risk factors? The blood pressure, intraoperative blood pressure was normal. There was no massive blood loss. There was nothing. It's a young lady, 38 years, not hypertensive, no dyslipidemia. So what could be the risk factor for a stroke? These are the things that are still, we presented this to add to the body of literature, probably to find out these are the things, experiences patients could have, in the course of having a procedure that is as common as abdominal myomectomy. So, LA toxicity, no, I don't think so.
Thank you, Dr. Job Otokwala. There have also been reports of severe post-surgical stress on patients causing stuttering or loss of speech. So that may be something we can also look at as a cause in this patient. You can never tell. Okay, do we have Dr. Adesina on call here so she can take the questions regarding our presentation? Dr. Adesina, are you on this call?
Okay, thank you very much, Dr. Okoje.
Thank you.
Can you hear me? Okay.
Yes, we can hear you.
I think I've answered most of the questions, except the one on the dose, 3.8. So we were expecting the surgery to last between 1.5 to 2 hours because it was going to be bilateral. So hence the dose that we used, because the woman was a bit anxious. We didn't want any issues with having pain or not. Plus that particular, as you know, most of our drugs, the storage is questionable sometimes, but we remained within the required dose. We didn't do an overdose there. Then as per the needle, those were the needles that were made available in the hospital at that point in time. That's the simple and short answer. As we all know, because of the needle size and her BMI and the multiple attempts, those were the factors that predisposed her to development of the severe spinal headache. Then there was a question on, are we sure? Yes, I think I've also answered that question. The time coincides with the time that we expect some resolution. But something that we noticed was the marked difference on introduction of gabapentin. For a woman that could not stand up from her bed, within 6 hours, she was able to stand up and eat and do a few things. And within 12 hours, she was up and going back to her normal activities. So there was a marked improvement, and it was very obvious. Then apart from that, at that point in time, we had stopped caffeine. because it was only causing her to be having sleepless nights, and it wasn't producing any relief for her. So we discontinued caffeine, and that was at the point at which we introduced gabapentin. Of course, we still had paracetamol on board. And we had used ibuprofen and the caffeine combination for a while. By the third day, yes, we had used it for 3 days without any significant relief at all in the symptoms.
Right.
So the
Thank
difference
you.
on introduction was very obvious. Thank you.
Thank you very much, Dr. Adesina, for the brilliant response. We have Dr. Olayinka Eyalade's hand up. You are recognized, ma. You have the floor, ma. Thank you, ma. Please unmute. Okay. Thank you, ma. Yes, you can go ahead, ma.
Thank you very much, Dr. Okoje. Madam Chairperson, I hope you can hear me.
Yes, we can hear you, ma.
Thank you very much. I want to commend Dr. Bilikis Mohammed for her presentation on epidural knowledge and attitude towards epidural analgesia for labor. That was a very good study. And I want to add that we also did the same thing in Ibadan. And our result was very similar to what she found. I think if she has interacted with the obstetricians as well, maybe she would also have known that apart from the low awareness among the patrons, some obstetricians are also of the view that labor should not be medicated. That is a natural process. You should allow as many women as want to go through it, rather than offering epidural analgesia. And of course, you know that the anesthetic personnel available to provide epidural analgesia are limited. And many times when you put in epidural analgesia, the obstetrician also wants you to sit down there to monitor the patient till delivery. So those are some of the factors militating against the increased acceptance of epidural analgesia in our country. Also, I have put some questions to Dr. Akinwale. I thank him for the presentation on palliative sedation and respite care in palliative medicine. So I know you have read some questions. Maybe you are still going to get there to read that question about the double effect of giving midazolam and morphine to a patient who already has respiratory depression. What is he going to do about that? Or was it a terminal sedation? And I think there are some other follow-up questions. Thank you very much, Madam Chairman.
Thank you, Dr. Olayinka Eyalade. Thank you for your work. We also had a similar work in UBTH, where we try to assess awareness of participants regarding epidural labor analgesia. That was part of my MPH work. And we found that it's even the nurses that discourages women from accepting epidural labor analgesia, because they are also of the same opinion that it should go naturally, and that even epidural analgesia will delay and make you have instrumental deliveries. And in fact, we need to do more work on this issue. Okay, now we go on to Dr. Akinwale. There's a question from Dr. Awodesu from Lasut. It said, thank you very much, Dr. Akinwale, on your presentation on respite care. Since financial constraints or stress is an issue for the caregiver, especially considering your case study, how can this be tackled, especially in our environment? I don't think looking after the patient for a short while may be enough to solve their problems. Please, Mr. Ediomi, can we mute the background noise, please? Then again, this is from Dr. Olayinka Eyalade. Okay, she just mentioned this. He said, my question on palliative sedation is this: how did you deal with the double effects of sedation and respiratory depression on the 64-year-old patient? Was it terminal sedation? That's serious. Okay, then this is from Dr. Adetoye. I also wondered what the reservations of the relations could have been, euthanasia or terminal sedation. Expatiate more, Dr. Akinwale. Okay, Dr. Akinwale, do we have you on this call? I think you should still be here. There are many questions on the chat box for you to attend to. Dr. Akinwale, are you here with us? Mr. Ediomi, is Dr. Akinwale still on this call?
I'm here. Can you hear me?
Okay,
Hello?
yes, we can hear you now, Dr. Akinwale. You have the floor.
Yeah. I thank all my organs for the question. So let me thank Dr. Tony Onyeka for the commendation. Then on effect of a double effect of sedation. Before I respond, there is a white paper by the European Association of Palliative Care.
Sorry, Dr. Akinwale, can you increase your volume? Sorry, we can't hear you.
Can you hear me now?
Okay, yes, better, please.
Okay.
Thank you. Go ahead.
I say before I respond, there's a white paper by the European Association of Palliative Care, which said that provision of euthanasia and physician suicide should not be included in palliative care practice. So I know there's only controversy between euthanasia, doctor-assisted suicide, and palliative sedation. But by definition, euthanasia is just killing on request. While doctor-assisted suicide is when a doctor terminates somebody's life by giving him or her the drug to kill by himself. But in palliative sedation, you are trying to improve quality of life when patient is having very distressing symptoms. When you see a patient that has is in agony, is mourning, restless, you leave the patient to die with agony. In palliative medicine, you want to improve quality of life till the end. So one of the ways to do it is to use palliative sedation. And as I've defined palliative sedation, it is done with the agreement after you have canceled the caregiver and the member taking consent from the caregivers. And about the double effect, well, there's what you call doctrine of double effect, which says that if you do something morally good, has a morally bad side effect, it is ethically okay to do it, knowing that the bad side was not intended. Now, for example, when a pregnant woman that had to do abortion because of the fetus may affect the health of the parturient. So if you don't abort the patient, the fetus, the woman will die. So which one is better? Do not save life of the parturient, but in palliative medicine, it is ethically acceptable to use medication to calm or to control any symptoms that you feel that is going to harm patient more than we look at the patient to go away. Euthanasia is not, in fact, there's a big controversy about the terminal sedation and euthanasia. But some people use terminal sedation with palliative sedation, but now it's no longer used. So it has been separated from, there's no like a terminal sedation again. Sedation is not being used. On the thing about Dr. Abudesu's question on respite care, there can be short-term or long-term respite care. It depends on the individual. You can take your patient if the caregiver cannot take care of the patient by themselves. You can take them to hospice. But unfortunately, we don't have long stay hospice in Nigeria. Where they are available, you can put your patient in hospice care as long as if hospice care is reserved for the patient who think is going to die in the next 6 months or more or less. So there can be long-term and short-term respite care. I think I've come.
Yeah, thank you, Dr. Akinwale, for the brilliant response. Thank you. Although we had some fluctuations in your network and your volume, but overall we were able to get one or two things from it. Thank you very much, Dr. Akinwale, for that. Now we have come to the end of this scientific session. We're supposed to have Mindray clinical specialist, Rojga Yangiri. Sorry if I'm not pronouncing your name properly. We don't know, are we having him here or Rogers, are you with us?
He's here, he can unmute himself.
Okay, there's so much echo. So he'll be talking to us on his product, this Smart Hospital. It's an online live presentation. That is Mindray, QRO, and ICU IT solutions. So Mr. Rogers, you have the floor for your presentation. Thank you very much.
Thank you so much. Let me share my screen. Am I audible enough? Hello?
Yes, we can hear you, Mr. Rogers. Thank you very much. You can see your screen.
Thank you so much. Okay, thank you for having me here today. This is my third presentation in your conference and I'm really humbled to be here. So I'm Rogers, I'm a clinical application specialist working with Mindray, based in Kenya. And today I'm actually privileged to be here. And kindly allow me, because the network is having a lot of issues.
Please, can we have you on slideshow? Sorry to interrupt. We need the slideshow.
Are you able
so we can see your screen fully.
Now?
Okay, good. Thank you.
Okay, all right. So I'm saying, yes. let me switch off my video so that I'll gather enough bandwidth for the presentation. The network is not so good. Okay, so today I'm privileged to share with you one of the fundamental questions that the global wave of digitalization seeks to answer is how to automate, simplify, and actually optimize the use of data, on how to manage our data in the hospitals. And with this, we are able to enhance operational performance of our hospitals and create added values in the process. And in the recent past, like every industry is striving to control and harness this data. So therefore, even healthcare is not an exception to this. So my screen is not moving. Let me stop sharing again, and then let me stop it and then share again. Okay. So, my objectives today is just a brief introduction, and then what are the solutions we have in terms of OR and IT solutions in the ICU. So moving into the challenges that we face every day in the hospitals, in the care of our patients, and in terms of data management, is that we have fragmented data, which actually compromises the patient safety. A patient is admitted today, the patient probably comes after 2 weeks for readmission. You're looking for these files, you're not able to get them. Changes of data and quality, data interoperability with other hospital systems. I'll just pick a few of them: risk of infections, and constrained transportation, that is pre-hospital and intra-hospital transportation in various hospitals. So we understand that you're transporting a patient from one unit to the other. There's a gap of monitoring of this patient. So you wonder, where can you get this data from? So this is what we're going to talk about today. And lastly, the telehealth consultations that we're able to provide you as a company. So here just shows a general scenario of an ICU bed with numerous beds, as you can see, numerous medical equipments. We have the ventilators, we have the ECG machines, we have the patient monitors, we have the infusion pumps. All these medical equipments are all generating a lot of patients' physical data and information. And this is the data that the doctors will use to actually diagnose their patients and have a proper treatment plan for them. So, but the question is, with all these medical equipment at the patient's bedside, how can you manage all this data, have a centralized data where you're able to get all this data without even losing them? So that's the question that we want to actually iron out today in my presentation. So in terms of infection controlling, especially in the COVID areas, you want to limit this, but again, you want to get the information for this patient. And then we understand there's time that you need to go in, there's time that you don't want to go in. So patients monitoring is interfered with. So how can you manage all this? Transportation gap, there is data that is lost during transportation. Again, in terms of ambulances, how can you manage all this data? And lastly, you have probably consultants who are not visiting hospitals every day, but you want to remotely consult with them and they want to look at the patient's information directly, real time. How can you manage all this? So these are the questions that we're going to answer today. And we all understand that is always a problem in terms of data management. As you can see, doctors have a number of files they need to look at. Like, for example, this doctor, there's a lot of data at his bedside, at this desk. It'll take a lot of time to look at this information. Therefore, you find there's a lot of time that is wasted in terms of patient care. This is an aesthetic, I believe, an aesthetic chart. This chart will be only understood by the person who did what? Who monitored this patient. A second person coming to check out this chart, it's really a problem to get relevant information from this chart. So therefore, if you can imagine, these are the underwriting that you have in your unit. The next time, trying to retrieve the patient's information probably after deterioration, you want to see at what point was this patient deteriorated. It's really hard to get all this information. Piling of information, like I visited a particular hospital, and this is where I found the patient's information are kept on the floor. Think of the environmental hazards, water and everything being rained on. And lastly, this is how it will look after a period of time. So you can imagine readmitting a patient after 1 year, you're looking for this data, you cannot even get them. So, and according to the study that was done by UK government, it actually stipulated that having a system where you're able to manage all these patients' information in a good way improves or has a lot of benefits in the healthcare industry, not more than one way. In that, number one, it develops better patients' profiles, and with digitizing patients' medical records, also it improves information availability and accessibility while increasing the likelihood of data being achieved. So the question is, you may be wondering, what is M-Connect now? So I'll briefly talk about what is M-Connect, the IT solutions we have in our ICU and OR, and how will this IT solution help you to solve these challenges that we face every day. So M-Connect is a platform with scalable IT solution, and it has three tiers. So what do I mean when I say 3 tiers? Bedside patients' information and devices. How can we connect all these patients' medical devices, different infusion pumps, ventilators, all this? How can you connect them into a central station? We can connect them either via a Wi-Fi, if the hospital is integrated with the Wi-Fi connectivity with the medical equipment, or secondly, via the Benelink. When you have our solutions, to a central station. And then the central station is the one that acts as now the storage capacity of all data. And we can again distribute all this information to different scalable solutions. You can have different solutions for monitoring your patient, like a workstation, a mobile viewer, and even a CMS viewer. And then from the central station, you can have now a third tier where you want to transfer all this information from the central station now into probably hospital information system for safe data keeping through the e-gateway. So these are 3 ways in which we can manage all this data: bedside, departmental CMS integration, and hospital information systems. So in short, or what I'm trying to say is that Here, in simple terms, health data management is the practice of making sense of that data that we've collected and managing to benefit the patient who is in between here now that this is our central main focus here, patient safety, to benefit the patient, the caregivers, who is the health provider taking care of this patient, and the practitioners, and ultimately the patient's well-being, and of course the medical equipment that we have in our units. So what is the clinical significance of all this? So with the doctors and even the anesthesiologist and all the doctors managing all these patients, they will have confidence with the comprehensive information at any time they want to look at it. For a nurse, if you have a mobile viewer, or even the nurse manager and even the head of department, probably the head of anesthesia, have all these solutions in their unit, they're able to check real-time patients' vital signs on their mobile phones. And for a biomedical engineer, what is the benefit of it? It improves the devices management efficiency via this a platform, we call it MIOT. So this is very important, how we manage all this data. So straight into OR, that is operating theater, IT solutions that we have, is that in theater we have challenges in terms of managing these patients who are undergoing surgical operations. The efficiency that we have as the healthcare providers for our patients. Sometimes you find there is distracted care for our patients. And then thirdly, the safety of our patient. This is very important. These are three aspects that we need to look at very carefully. So under patient safety and increasing the efficiency of your operating rooms is that you receive a patient from the general ward. In the preparational room, you can just scan the code to identify and admit patient to M-Connect IT solutions. Use a barcode scanner like this one. You have a scanner, you scan and then get all the information, and then directly the information is sent to probably the patient monitors and medical records of your unit. And then in the induction room, from the preparation room, plug and play is an automatic synchronization of the patient's information and vital signs, and you're able to get all this information. In the operating room, there's no, again, connecting of data again, connection of cables to your patient. What you did at the preparation room, with the use of that patient monitor, we call it N1, it's a transport monitor. You don't need again to connect the cables. You just plug in and that information is synchronized directly to your patient monitor that is in the operating room. And then once you're done with the operation, you can transfer your patient to the recovery room with the same transport monitor, and you will get all those information seamlessly without connecting any cables again, only moving with only one dart, only one patient monitor. So with this, you're able to actually increase your efficiency, and time of care of patient is really increased. The second challenge, again, we're getting here is in theaters, we have so many medical equipment. Name them. Infusion pumps, but you have defibrillators, all those information that you'll have from all these medical devices. How can you solve all this information? Because they're generating data. So we are able to integrate the medical devices you have in your unit. For example, you have infusion pumps, you have anesthesia machines. You're able to integrate all that data that is generated from these machines via the module called the BenderLink that is able to accommodate up to 4 medical equipments. As you can see here, we have 4 ports, meaning that you are able to accommodate up to 4 medical equipments. And via the BenderLink, we are able to transfer all this data and synchronize it to our patient monitor, So again, we are able to have another module called an iView module that is meant for our premier segment, the patient monitors, where you connect this to a patient monitor and you're able to get information from the PAC system. The only thing you need to do is insert patient information and you're able to get this, and I'll show you in the coming slide. So for example, you've connected all these medical equipments, the infusion pump and the anesthesia machine Into the next slide, you have the multi-parameter monitoring. It doesn't interfere with the patient monitoring parameters and the vital signs. At the same time, you have the anesthesia information system on the patient monitor that you integrated with the patient monitor, and the infusion pump. There's a window for it. If you're giving, for example, propofol, you're giving labetalol, all the intravenous drugs you're giving via your pump. You're getting that information on the patient monitor, and you're able to get real-time data being displayed on the patient monitor at the same time. Again, I talked about the iView function, which is the module that will be embedded in our patient monitor. With that, you're able to find patients' information from the PAC system. For example, this is a digital X-ray. You're able to get this information in theater without struggling or even asking probably the running nurse or people from the wards give us the physical X-ray films. The only thing you need to do is insert patient information, go to the PAC system and get all this information from the radiological department. So it improves the effectiveness in diagnosis and timely treatment of patients. So that is about the solution we have with our OR. So moving to ICU, these are the challenges that we have. Patient safety, that is priority. Number two is in terms of efficiency. There's a lot of workload, there's complex workflow. And we all know that most of our hospitals, they're understaffed. So how will these IT solutions help you actually to increase your efficiency? So with our comprehensive integration that we have, is that we are able to integrate our ventilators, infusion pumps, and other bedside medical equipments, and can be integrated into a patient monitor, ventilator, infusion pumps via the BenderLink module, which can accommodate up to 4 medical equipments, as I had said, into our patient monitors via this BenderLink module. And all this data from the devices are organized by the patient with a unified time span, and the patient's identification is sent automatically to the, for example, electronic medical records. And this will actually reduce a lot of paperwork for your unit, and it will improve the work efficiency. In terms of diagnosis and timely treatment, as I had said earlier, if you're integrating your infusion pumps, the same with anesthesia machines. So you have only one medical equipment that you are focused at and looking at the kind of solution that you're offering to your patient. So it improves your reliability in terms of your diagnosis and decision-making in your unit. So another one is about the closed loop management, where, for example, you have this system in your hospital, probably in an ICU. So as a doctor, you find there's a problem in terms of the patient's parameters. You recognize from a central station, you send a prescription to the nurse, and then the nurse confirms the prescription. Into the pharmacy, they will dispense the medication, for example, that you've prescribed, and then the nurse will prepare and label the medication and give it to the patient. So at no point where you'll find there's a gap of care to your patient, there's timely prescription to your patient, there's timely response, because all these are in the system. And if somebody will not go and attend to it, the next person will come and see, okay, actually this was not done, and you'll question this. So it will actually improve on how you manage your patients effectively in your unit. So with the same thing, again, I had alluded earlier about distributed monitoring of your patients, for example, in the ICU. So you have all those machines into the central station, and then from the central station, which manages the data of all the bedside medical equipment, you can have different monitoring equipment. You can have mobile viewer, you're able to see all the patient's information, especially alarms and other things. You're able to see them there. You're able to see on the corridors or even on the lounge where you're seated, you can have a screen that is there, and it has the patient's information. You're able to see what is happening to your patient, the critical care units, especially the isolation units. And lastly, the workstation. So you're able to access data anywhere, everywhere, at any time. The silent ICUs, especially, you find you will want to have a silent ICU where you don't really, every time you don't need to go to these units. You turn off all the medical equipment, audio, keep silence in the wards, enhance recovery of your patients. And with this actually will really enhance and avoid unnecessary contact. And especially with COVID-19, it will reduce a lot of infection to your patient. Another thing is about transportation, which is about a challenge. I mean, a challenge that we normally face every day. You have a patient from your unit, you want to transfer, or you want to take this patient to a radiological department to do probably an investigation. But you have monitors in your unit which you cannot use as transport monitors. So with our N1, you can unplug it from the main unit. You transport your patient to the radiological department. For example, you want to do a CT scan, and then back in the unit. And at no point, you'll have interrupted monitoring of your patient. And you don't need again to connect the reconnection of the patient's cables. And the upload is automatically, so long as there's Wi-Fi connectivity and integration within your hospital, within one system. The same thing I've just explained. And then we're able to synchronize all this data from the bedside, central station, into the third-party information system. For example, hospital information system. For example, a medical officer is seated in his office, is able to get the information of a particular patient or a particular bed in ICU from his office seated there. So, which is really good IT solution that we need actually to embrace in our hospitals. The same information I've just explained, and we are able to interoperably, operational of all these medical equipments with different systems. Like for example, the PAC system using the IV module. You want to get information from the LIS, the lab information system. You need to get information from the city. All this, you're able to synchronize this and give you all this information into our patient monitor that you have in your systems. So the question is, can this help information technology help in improving our patients' care, especially in our African setup, in our African hospital setups? And what does the future hold in terms of IT in healthcare? So this is an example of a hospital here in Kenya. This is a hospital called Kenyatta University Teaching and Referral Hospital. And in the wake of COVID-19, where you find we employed all these solutions. And as you can see, this is a screen which is deployed on an office of the doctor, and is able to monitor every detail of the patient which is happening in the COVID center. In case of any deterioration in patients' vital signs or anything, is able to see everything and is able to actually act very fast. And Kenyatta University Teaching and Referral Hospital is one of the major biggest hospitals in Kenya, managing these COVID eras. And by embracing this, it has really managed to help their patients recover well. Like 60% of the admission that we've had in these hospitals, they've gone home well. And thanks to the IT information that we were able to help them to do and manage all this. So again, another example from one where we had the origin of COVID-19. The same, you see, these are ICU staff getting the information from the PAC system, the X-ray, and they're able to manage their patients well. This is the workstation. They're able to manage their patients without no gap of monitoring. These are the doctors in their offices, and they're able to see what is happening to their patient in their units. You're at your home as a consultant, and you have your patient in an ICU or in theater. You want to see the vital signs of your patient. You're able to see all this on a mobile viewer. So all these solutions can be employed to actually enable efficient patient monitoring in various units that you have in your hospitals. The same thing about telemedicine and teaching. Probably the hospital is a teaching and referral hospital, and as a way of preventing infection to the students or even people who will go to this unit, and actually you want to limit the number of people who are going into the ICU. So you can project all that patient's information, physical vital signs and information into a screen. And you're able to discuss amongst yourself as consultants. As a lecturer teaching the students, you're able to get all this information and you're able to discuss all this information with it. And then experts exchange with the different countries. So long as you're able to get all this information, IT connectivity done, you're able to communicate with other experts from other countries, and you're able to display to them the real-time patient vital signs, and you're able to discuss all those information, all that data at that time, and how the patient is presenting. So that is the end of my presentation. I really thank you guys for listening to me and giving me this opportunity to really share with you this information. So I really look forward for us to employ all this in our hospitals, and we'll be in a position to really manage our patients very well. Thank you so much.
Thank you very much, Mindray. Thank you for the excellent presentation and the innovation. Mindray, I've always partnered with the NSA, and we always appreciate it when you support us in our work. Thank you very much. We don't know, do we have questions for Mindray presenter? You can raise up your hand if you have a comment or a question for him, or you can just simply type it in the chat box. In my Mindray, I've also included their address on the chat box. You can actually copy it so that you can reach them after this conference for all your needs about the products they've advertised on this platform. They have their Lagos branches there and the phone numbers. And I guess they also offer post-service sales, maintenance, and then delivery. Okay. In the absence of further comments and the contributions, I will now hand over to the Vice President or the LOC Chairman or Madam President herself to take over from here to give us the closing remarks. We want to thank all our presenters for this session. Thank you for all your work. We hope to get more scientific publications and encourage more of this kind of novel practice so that we can improve our practice. Thank you very much for sharing with us. Thank you, all the presenters. At this junction, I now hand over to Madam President or Dr. Yakubu. Can see you. Thank you, LOC Chair. The floor is yours. You can unmute yourself, Dr. Yakubu.
Thank you very much, Sec Jen. I want to thank all our presenters, our members, and everyone here for supporting us during this conference. Thank you very much for all the participation, the contributions you've made. We thank all the pharmaceutical companies and their representatives for supporting us. Thank you. Is Madam President around, please?
Okay.
Yeah, Dr. Yakubu, LOC Chairman, thank you very much for the session. We have come to the end of the session with the vote of thanks by the LOC Chairman. However, we have to appreciate all those that have made this possible by appreciating the local organizing committee. We will also appreciate our presenters. They've been appreciated on individually on the different days. We'll appreciate all the abstract presenters, and then we will appreciate those that we called up for awards that didn't come, that were not present to pick them up. So we just have 20 minutes because we're behind time by 1 hour, 20 minutes. So these awards were supposed to take place from 12:20 to 1, and we're already, it's 1:26. So I want to plead with us so that we quickly take just the mention of the names of the members of the LOC, and then we take our break and go into the annual general meeting too, and then have the final closing ceremony at the end of everything. I don't know if that is accepted by the
Thank you very much, Ma. Thank you. Actually, today is Friday. The way we fashion is that by 1 we go on break and we come back by 2:30, because some of us have already left to go and pray. So since it's about 1:30 now, I guess we should take the 1 hour break so that we all come back by 2:30 and then quickly do the award and then continue with our AGM. Thank you.
Okay, so thank you very much for that clarification. Yeah, that's a good plan. I agree with you entirely. In fact, I thought we will have ended since before 1. Okay, so let's do it like that. So we will reconvene at 2:20, 1 hour break or 50 minutes break. We'll reconvene at 2:20 so that we start the proceedings by exactly 2:30 prompt. Thank you so much. I appreciate all those that presented, all those that are with us and participated in this session. Thank you and God bless. Bye for now.
Thank you very much, Ma.
Don't forget to join up again.
Thank you.
Again, is the same link. Don't forget to join up. In the interim, I will request the, thank you. I will request Mr. Kovani not to go away, to do a slideshow of all our awards and certificates, to keep playing them on for the 1 hour with background music. Is that possible? Mr. Kovani, could you do that, please?
Sorry, ma, please say that again. What do you want me to do?
You have a slideshow of pictures of the event so far, and then our awards, the plaques that are ready and the certificates that are ready, presented as a slideshow continuously with music while we are away, instead of closing shop completely.
Ma, we won't close shop completely.
Okay. So you normally put the video of your health mates. So, okay, don't put health mates, put NSA videos, put the NSA webinars, put the videos that we did before about NSA, then put these plaques that we've had today and be playing them about whatever you are putting, let it be about NSA till we come back. Thank you so much.
Okay, ma.
Okay, thank you.